Yeah, good afternoon, everyone. We welcome you to Ortho TV Online, and this is the second day of the midterm ISSH hand CME. And over to Dr. Parag Lat.
Good evening, everyone. Welcome back. Today we have, again, I would like to welcome all my senior faculty and speakers for second day of CME of Hand and Wrist Surgery under auspices of Indian Society of Surgery of Hand. Today we are going to have wonderful discussion on distal radius, carpal injuries, infections in hand, etc. I would like to welcome my moderator, Dr. Pankaj Ahire, and he's going to start the proceedings now. Over to Dr. Pankaj.
Afternoon, everyone. We had a wonderful the first day of the sixth midterm CMA of ISSH yesterday. Last evening, around 5,000 plus surgeons across the world visited the CME, and that the feedback has been extremely encouraging. So today on day two, we are going to look at the more of wrist pathology, wrist fractures, infections, tendon injuries, and usage of splints. We have faculty who is spanning across the country. Yesterday too, we had a faculty representing all zones of India. So we are looking forward to an interesting day today. My co-moderator for this session is Dr. Ashish Padnis, brilliant orthopedic surgeon from Jupiter Hospital, very well respected among orthopedic circles. Those from plastic surgery background who may not know him, so this introduction just describes him perfectly. Over to you, Ashish.
Thank you very much, Dr. Pankaj. And again, I would like you to welcome on the second day of this sixth midterm CME. And without wasting any more time, we would start with the first talk of the day. And I would like to ask Dr. Rohan Habbu to start with the radiological approach to the distal radius fractures. And looking forward to a wonderful session for the next hour and a half. Over to you, Rohan.
It's by far the most commonest injury that everybody sees in their clinic. And if you see these four X-rays, these are the variety of fractures that we usually see. It could be as simple as the one on your left. It could be quite innocuous as the second one, but if you give a plaster to this, it could settle down. It could be something like the third one, which we might miss, an obvious complicated distal radius fracture. So how do we go about making a diagnosis? For that, we need to have good X-rays. Almost over 90% of the X-rays would, rather 90% of the injuries would require X-rays and nothing else. You need a good PA view, a good lateral view, and occasionally a scaphoid view if you're suspecting an additional scaphoid fracture. There's always a confusion, why a PA and an AP? We use a PA view because it's easy to place an injured wrist palm down rather than palm facing up. And additionally, you can get a good profile of the ulnar styloid if you get a good PA view, and you will be able to pick up even innocuous ulnar styloid fractures. So a good PA view would give you almost all the fractures. We might miss a bit of the shear fractures like the volar lip or the dorsal lip. You'll be able to pick up the distal radial joint injuries, as well as any dislocations of the radiocarpal joint or the midcarpal joint. A lateral view is typically taken with the wrist perpendicular or the hand perpendicular to the X-ray plate. It gives you a good position of the fractures, whether they are volar or dorsal. It gives a good position of the carpus, whether it is volar or dorsal to the long axis of the radius. It gives you the position of the DRUJ, like the one in the bottom screen, where there is a volar dislocation. And if you carefully look at it, you would get a good carpal alignment as well. Sometimes you have a good normal X-ray on the lateral, but you're suspecting something at the lip. So this is something that everybody does probably on table to see the intra-articular placement of the screws. You can also do it as a pre-op projection so that you could pick up the good teardrop. You can pick up a lot of volar lip fractures with this. You could pick up the widening of the distal end of the radius. And something that you would have planned to cast, you may end up fixing it. Everybody has seen these angles, and these angles are quite important because they tell us the intensity of the injury and what was the primary displacement of a fracture. You measure the radial inclination, the radial shortening or the radial height, and you measure the volar tilt. For me, in our practice or in most of the papers, is the radial height that's quite the most significant among the top three. A good PA view would give you an idea of the DRUJ of the ulnar styloid. A subtle hint in the bottom picture would be a positive radio-ulnar variance that can happen in a very innocuous distal radius fracture. You could also pick up good or very small styloid fractures as in the top picture. So why do we see these X-rays properly? Because we want to treat it right. You either want to fix them or you want to cast them. Then you kind of describe them in different classifications. But what we have found is most of the classifications are either confusing or are not prognostic. For example, this is simple classification like this, or a classification based on one particular segment of the distal radius. You could have based on the multiple segments of the distal radius. You can have it based on the mode of injury. And the favorite amongst all is the classical AO fracture classification, which it describes it into extra-articular, partial articular, and intra-articular. The problem with these is you may not be able to give a prognostic significance or decide what you want to do. So in a distal radius fracture, what we want to know is what is the stability of the distal radius injury. Now, if you know it's stable, you can get away with just simple non-operative management. And if you can predict that it's unstable, you can discuss operative management with the patient. So for example, clinically, if it's a high velocity injury or an open injury.
Rohan, this is Dr. Warrior.
Yes.
There seems to be a small technical problem. It's not yet streaming live.
Oh.
If we could just pause for a couple of minutes till Ashok gets it online and gives us the signal that it's online, or Neeraj gives us the signal, because we're getting
Yes. I'm just talking to Ashok. Rohan, just wait for 2 minutes.
Right.
Yeah.
Do I need to start all over again?
I think I don't mind you starting the presentation again. Because nobody has seen it. Ashok, I am just talking to Ashok. Wait.
Yeah, I was just checking it actually. So I was wondering whether there was any problem at my end.
No. I just spoke to Ashok. He's traveling. That's why he has a signal issue.
Okay.
Ashok. Okay. We will wait.
No problem.
Wait for 30 seconds, he said.
Would you let me know?
Yes. I will just let you know. Wait.
No worry, guys. I will cut down 2 slides out of my 120.
Don't worry. Don't worry. Mine is 5 minutes.
No, there's no point us continuing because no one's listening, by the way.
I was, in fact, when I played yesterday's videos, and then it went on to some other webinar.
I tried the same thing and I got 2 messages.
Yes, sir.
Neeraj, is Neeraj here?
It is live now.
Okay, I think Rohan, you start it again.
Yeah.
Live आता है.
Yeah, it is live.
You start the introduction.
Yes, you can start again. Sorry for the delay.
ठीक है मला तिथे की
Okay.
ओपन होतंय का बघायला लागेल.
All right. Hi. Good evening. This is Rohan, and I'll speak to you briefly on radiological approach to distal radius fractures and what goes into the decision making based on the radiographs. The distal radius fracture is by far the commonest injury that everybody sees, and this is just a small spectrum that amongst the variety of cases that we usually see in our clinic. As simple as the one on the left, as innocuous as the second one, a simple one that can be missed and have grave complications later, and an obviously a complicated one on the right side. So whenever we see a distal radius fracture or an injury to the wrist, the 2 commonest radiographs that we should all take would be the PA and the lateral view. And if you're suspecting a scaphoid injury, then go ahead and take a scaphoid view. There's always a confusion between whether to take a PA or an AP view. We always prefer a PA view because it's very easy to place an injured wrist with palm flat on the surface rather than the other way around. And it also gives you the ulnar styloid in profile so that you can pick up a majority of the injuries on the ulnar side. A good PA view will give you almost 90% of the fractures or maybe more. A little ones on the volar lip or the dorsal lip could be missed, but you can pick it up if you carefully observe the lateral view. A lateral view is taken with the hand perpendicular to the plane of the plate. It gives you almost all the fractures. It provides you with the position of the carpus in relation to the long axis of the radius. This is quite important when you have lip fractures, and you could see whether it is moved or shifted volarly or dorsally. You can also pick up the DRUJ position, like the one you can see on the bottom, which is volarly subluxated or dislocated. A tilted lateral view is commonly taken when you're operating or plating a distal radius to look at the screw placements, whether it is intraarticular. In fact, it can also be taken pre-op so as to study the volar lip. It gives you a very nice view of the anteroposterior width of the distal radius and allows you to make a decision of whether to plate or cast such a fracture of the volar lip. Everybody has seen these angles, and these are quite important so as we know how much displacement is there primarily at the time of injury, because that decides what goes into the management. You can have the radial inclination, the radial height, and the volar tilt. For me, it's the radial height that's the most important amongst all the three. The ulnar side injury is also important, so never miss it. You can have an innocuous fracture of the ulnar styloid like the one on the top, a small widening of the DRUJ like the one on the bottom. This is quite significant if missed. And a subtle positive ulnar variance in an innocuous radial radius fracture, which can also lead to ulnar impingement. So these are quite important, and that's why you need to study the DRUJ as well on a PA view. Classifications by far don't give a prognostic significance, and there are many of them for the distal radius. This one, which is the simplest, you could base it on one particular facet of the distal radius, or you could base it on the multiple facet of the distal radius. It could be based on the injury. And the commonest one is the AO1, which kind of gives you some prognostic significance or the severity of the injury. If at all you want to follow something, this would be a good one because this will standardize your fracture group amongst most of the studies that are done overall. But what we need to know, except apart from the classification, is whether your distal radius is stable or not. For example, if it's a high velocity injury or an open injury, almost always these fractures are unstable. So by unstable, you mean we need to give some stability by fixing it. Shear fractures or comminuted fractures can also decrease the stability, and that's what you need to see. There are many predictors of instability in the distal radius fractures. The three commonest or the most important ones are age, which is more than 60 years of age, comminution, both volar or dorsal, or even comminution of the DRUJ, and the loss of radial height. And when I say loss of radial height, it's at the index or the primary X-ray. Like I said, a major DRUJ injury like this will also cause a lot of instability, and these fractures typically are not amenable to plaster fixation. You need to fix them well. So when you see an X-ray of a wrist injury, what you need to know, you don't need to know any classification. What you need to know is whether it's an extraarticular or intraarticular injury, whether there is combination volar or dorsal or both. What is the primary displacement? And that's where your inclination, tilt, and radial height is important. Look at the quality of the bone and look at the DRUJ. If you answer these well, you would know whether you want to fix it or whether you want to put a plaster. For me, in my practice, CT scan is not such a big part of managing a distal radius injury. I would say 90 out of 100 fractures, we don't do a CT. A CT would be done if I'm suspecting a volar lip injury or a shear fracture. If I'm suspecting a die punch fracture, which will not be seen on the best possible X-ray. So in about 10% of my wrist injuries, I would get a CT scan done. It allows you to define the complex fracture patterns. It also gives you an idea of how depressed the articular. An MRI almost always is not needed. Means I might have done just one MRI in the last 7 years. That was primarily for to rule out a major ligament injury, and that's what we were suspecting when there was a very bad carpal view. So the take-home message for this lecture would be you need to get good radiographs, and good radiographs, a good PA and a lateral view can give you almost 90%, in 90% of the cases, allow you to make a decision of whether you want to fix it or whether you want to cast it. You need to know the mode of injury. You need to know whether there is intra or extra articular component. What would be the initial displacement? Look at the combination, both volar, dorsal, as well as on the ulnar side. Look at the bone quality and look at the status of the distal radioulnar joint. It also predicts whether you will have a good result or not. Thank you so much.
Thank you, Rohan. And Dr. Parag, are we taking the questions now or we take at the end of the session?
Hello. Questions we will take after 3 talks.
Okay. So very succinct and a very crisp talk, Rohan. And I would like now like to invite Dr. Patankar to talk to us about the role of K-wiring. Having looked at the X-rays and the imaging, now we'll proceed to start to fix the fractures. So we'll have 2 talks in succession. One will be Dr. Patankar's of the role of K-wiring and the external fixator in fixation of fracture of the lower and the radius. Good evening, sir.
Am I audible?
Yes, sir.
Yeah. Thank you, Parag, again. And Rohan, thank you for simplifying my job. Actually, this is probably the most commonest presentation of the hand injury that we see in practice, the dinner fork deformity, traditionally of Foley's fracture. And as Rohan has said that we require X-rays. We are totally dependent on X-rays, occasionally a CT scan. What is most important in these X-rays is that you have to look at the dorsal angulation and dorsal comminution in a fracture, and you have to see the sharp polar spike on the lateral view. These two, according to me, are the determinants whether a closed reduction is going to succeed, a K-wire is going to succeed, or what problems you have in store for you. The commonest thing, or this is probably the first surgery that we do in residency, first major surgery apart from suture removal and implant removal, is putting a K-wire in the distal radius. Now, various combinations of K-wires have been practiced, and I will not go into that. A retrograde wiring, trans-styloid pinning, or even the Kapanji technique. These all are fine. They work very well if there is no combination, but most probably, most of the problems are when there is a collapse, it is cause loss of reduction. And that is mainly due to 2 things. One is that we underestimate or we don't calculate the amount of dorsal comminution, especially in elderly people. And we don't calculate the volar spike. If the volar spike is not reduced properly, then we have this loss of, we have got this loss of height, a positive ulnar variance, and a dorsal tilt. In fact, a positive ulnar variance, in my opinion, is more disabling than a volar tilt. And eventually it leads to a painful restricted forearm motion. In my opinion, a painfully restricted forearm motion, a painful supination and pronation probably is more disabling than a restricted wrist movement. So we go to this case of an extra-articular fracture. This was a relatively younger patient. You can see even in this case, there is a dorsal collapse, a dorsal spike here, and this volar cortex is not reduced. You can see that the volar cortex is not reduced. Now, unless you reduce the volar cortex, no amount of K-wiring is going to succeed. And in addition to this thing, always you will have a hidden or unknown dorsal comminution. So you always must give a slab, keeping the wrist flexed, and always reduce the volar cortex. If your volar cortex is reduced, and then you, whatever pinning you do, you have to support it with a dorsal slab, and that's the fracture which is healed, and that's the volar cortex which is very well reduced. You can see that even the dorsal cortex has fallen in line. The slab has to be maintained, keeping the forearm in supination and the wrist flexion for about 3 weeks. And very important thing, while inserting a K-wire, when you want to insert a K-wire through the radial styloid, identify the superficial branch of the radial nerve, identify these two extensor tendons of the first compartment, isolate them, and then put in a K-wire. Don't do it without that. When you want to put a K-wire through the dorsum or from the lateral aspect, identify the EPL tendon or the common extensor tendons if you want to do a Kapanji technique, and then only you put a K-wire. Don't do it blindly. If your tendons get stuck up there or get impaled by the K-wires, then will be a big problem. So in the post-operative phase, when I treat the patient in a plaster, if and when I treat the patient in the plaster, I always give a below elbow, above elbow POP slab for about 3 weeks. The elbow is maintained at 90 degrees. The forearm is supinated. The wrist is flexed to give a dorsal periosteal support. The thumbs and the wrist fingers are kept free, and I ensure that the patient is doing a shoulder abduction right from the first day. That is the way the patient is enjoying the exercises. You can see that the patient is extending and flexing the fingers and even abducting the shoulder. So there won't be any shoulder hand syndrome or any shoulder stiffness in the long run. Now this is again a case I would like to again reiterate that this sharp volar spike causes the loss of reduction, or that means that the reduction is not well maintained. The dorsal angulation and combination is very important. You can see with the radial styloid, we must remember, is a slightly volar structure, and then the K-wire has to pass one right in the midline here, and one K-wire is to be passed slightly on the dorsum to give a good hold. And that's how the volar cortex is reduced. And that's the post-op picture of this patient treated in a plaster. And you can see with this, all these precautions, you can see all the radiological parameters are very well maintained in this patient. Now, that is not the case in every case. The dorsal combination is quite extensive. Now, if you ask the options in this case, the first option will be a plate, second option also will be a plate, and third option will be also a plate. But I came across these articles way back in 2002 and 2013, and we kept on wondering whether we can use it for our cases. And this case, we are treated it with this patient with this method. We use a close reduction, we reduce the volar cortex, and this is a minimally invasive technique by which two antegrade wires 1.5 millimeter in diameter are passed in this manner. One wire goes to the radial or radial volar corner, one wire goes to the dorsomedial corner. The third and fourth wire, one wire is passed interfragmentary and one wire goes intramedullary. Now, the wires are cut superficial to the tendon. The skin is closed, and in this case also a plaster is given. You can see all the radiological parameters are well maintained initially, immediately post-op also. This paper is under review for publication, by the way. So now we always compare with the normal side. You can see that there is a restoration of all the radiological parameters in the follow-up. All the 4 X-rays we are taking, oblique views, PA and AP, and the lateral view. And this is, you can see, it is a minimally invasive surgery. There is hardly any scar. There is no problem. There is no tendon or nerve problem in this method. You can see a very good result here. And that's at implant removal. And you can see that all the parameters are very well maintained by this antegrade nailing technique, in which it does not allow the collapse in face of dorsal combination here. That's a pre-op for comparison. The advantages of this method are that it maintains the reduction. There is hardly any collapse. The cost is very minimal in front of a plate. The plate costs about 40,000 rupees, an imported plate. This cost, the material costs about 2,200 rupees only. There are minimal complications. If necessary, if desired, you can augment it with an external fixation in a comminuted case. And you can also do it in children, as I'll show you. This is an epiphysis pairing technique. This is a case where a badly displaced fracture, not amenable to a close reduction. This was treated with antegrade nailing. This is immediate post-op X-ray. That is at 1 year post-op. And that is the complete function that is regained. The growth also is normal. This patient has gone and become a doctor now. Now, this is a case where this is a comminuted fracture with intra-articular extension. You can see that there is some amount of bone left here. We'll always do a CT scan in this case to assess the prognosis or assess the problems. Now, in this case, I use this AO type of external fixator where we use a Fernandez type rod-to-rod clamp here. And this advantage of this rod-to-rod clamp is that you can put the pins anywhere you want in the metacarpal and in the radius, and then you do a close reduction. You can augment it with external K wires, and then you connect this rod-to-rod clamp and get the desired position, desired ulnar deviation, desired flexion. That is very important in these dorsally comminuted fractures. If you get the desired flexion and maintain it with this rod-to-rod clamp, your external fixator will serve as a permanent method of treatment. And we encourage shoulder and hand movements in this case, and that's the result after implant removal, and that's the normal and abnormal side for comparison, and that's the final follow-up. Now here again, option would be in this case, in probably in this era when dorsal distraction plates are available, why do external fixator? That also is a very viable option. I did a external fixator in this case only because the dorsal plates were not available. This was done out of Bombay, and you can see very important is to restore the DRUJ. As I've said, that intra-articular fracture will not give a problem if the mid-carpal joint is normal and the DRUJ is normal. So in this case, we opened it dorsally, put a bone graft, maintain this flexion with a rod-to-rod clamp here. You can, the advantage of this is you can change the assembly if you feel necessary. Now you can see at 6 months post-op, the carpal alignment is maintained, the DRUJ is maintained, the ulnar variance is maintained. The intra-articular step-up does not matter because anyway, we expect the radiocarpal joint to become stiff, but however, mid-carpal joint will compensate. And you can see this is a very good result at 6 months post-op for this particular case. Now this is the last case. Now this also is a very good indication for a plate, but I felt that clinically there is a lot of comminution. Imported plates were not available for this patient at that time. And there was an intra-articular extension and patient was not affording a plate, imported plate. That would have been very good for him. So I treated with a close reduction and external fixator. You can see again, this Fernandez rod-to-rod clamp is in action. It helps to maintain the wrist in flexion. Now, when the pins are going into the second and third metacarpal, you will always expect MP joint stiffness here. So this fixator, we have attached it to the MP slings, a splint, and you can start splinting and start MP joint flexion right from the first day, even in spite of the fixator. And you can see that fracture is healing very well here. And that's the hand in motion. We, in spite of the fixator, that's the fracture which is completely healed. And that's the function after about 1.5 years. You can see even he has got a very good flexion, very good extension here, full rotation of the forearm, absolutely painless and fully functional. Now, the message I want to give is that try to use minimal, less diameter pins. 2.5 millimeter pins are very good. AO type of clamps are very good. And you take limited incisions while inserting radial pins. Keep the MP joint flexed while inserting the hand pins. The shoulder and hand joints should be moved right from the first day to minimize the stiffness. The intramedullary KYs, you can insert them for assisting or maintaining the reduction. If the distal ulna is unstable or gets displaced, you can stabilize this also. In brief, you can say that I like to use the Fernandez classification. For shear fractures, I prefer K wires. You may or you can also use a plate. For bending fractures, you must use a plate. I think I got it wrong. For shear fractures, you should use a plate. The bending fractures, you should use only K wires. For compression fractures, you must use a plate. You can combine it with external fixators. Avulsion fractures are generally amenable to K wires, and combined fractures, you can use the combination of all of them. I thank you all for your attention.
Thank you very much, sir. And we would go to the next talk by Dr. Warrior on indications and techniques of plating of the fractures of the lower end of the radius. Over to you, sir. Good evening.
Dr. Warrior, we cannot hear you. Can you unmute yourself?
Yeah.
Now, can you hear me now?
Yes, sir.
Yeah, thank you, Ashish. A lot of my job has been made easy by the preceding two talks. So I'm going to rush through this, which ones to operate. Hemant has already spoken about it, and so has Rohan. But it's basically the ones that are displays considerable comminution with osteoporosis and polytrauma, and when there is considerable ulnar-sided instability. If it's an intra-articular fracture, then you should look for the separation, whether it's impacted, whether you can reduce it or not, and then again the same indication. So I won't dwell too much on that. I'm going to go more into what we do when we see the patient and when we decide to do an operation. Well, the first thing is to decide the incision. And most often we take a volar incision for volar plates. Most of the plates are on the volar side. You must open the radial aspect of the FCR sheath. Do not open on the ulnar side and dissect between the FCR and the radial artery. The important thing is not to allow any retraction there because there's only 7 millimeter space between the FCR and the median nerve. So if your assistant is a strong assistant, you're going to have trouble there. If you pull that across, then the median nerve and the superficial branches to the palm are going to be affected, and you're going to have a very painful post-operative scar. The disadvantage of a straight incision in this position are the fact that it's difficult to reach the ulnar corner at times, and you might have to then go on the ulnar side and try and approach this again. The other problem is that you tend to kink the median nerve far too much because of the pressure. So therefore, sometimes in most of the cases now, over the last 2 or 3 years, I've been using a darted incision. The dart is over the crease and it eases the tension. The incision is still the level of the radial styloid. The flap permits reaching the ulnar corner with lesser tension, and this incision can easily be extended into the palm if you need to do a median nerve release or a carpal tunnel release. And this is one such incision that you can see the ease with which you can reach the ulnar corner and with less attraction. I also like to use the GLP type self-retaining but blunt-tipped single-pronged retractor. It's a single-pronged, blunt-tipped self-retaining retractor. What about the scar? Since we've been doing this dart in the incision, you can see the scar on the right side. It's barely seen. And in the ones that were there in the earlier, and it's surprising that when I look back and I have so many of these pictures, you can see that towards the crease, you can find thickening of the scar. And you can understand that these are not patients prone to hypertrophic scars or keloid formation. These are patients because they have a normal scar proximal to that, whereas the other scars are practically imperceptible. And this is something that we need to look at. Going straight on to cases, here's a 61-year-old very active man, and the volar spike is pretty obvious. The ulnar fracture is obvious. The comminution is obvious. The need for something to be done is extremely glaring in the face. A CT scan helps to try and tell you that you're in trouble. More than that, it really does not help too much. The X-rays can give you as much information, and I agree with Rohan that oftentimes it's not really necessary for getting a CT scan. But yes, when you're planning to do a plating, whether you want to put it on the volar side or the dorsal side or the radial aspect, sometimes a CT scan is very, very helpful. Now, in this case, I proceeded to do a volar plate. But then there were fragments that were a little loose, and you can then add either a headless screw or a small screw with a washer, or you could also fix it down with just K-wires, as I've done here. What next? You need to do the ulnar as well. So you need to be careful of the ulnar, the dorsal branch of the ulnar nerve. You need to identify it and get it out of the way, and its branches, if you come across them, don't cut them. These are the worst nerves to get a neuroma from. So you need to get a small plate there, a 2 millimeter plate. So you need to plan this in advance. This does not come in the distal radius set. You have to ask for the 2 millimeter set. Only then are you going to be able to put it together like this. This gentleman was under the care of 6-7 surgeons post-operatively, and happen to get a CT scan, which is fantastic, because if you get a good CT scan, you know where your screws are, and you can see here that all the screws were in a very good position, and the fragments, all of them seem to do extremely well. He had a preoperative ulnar nerve disturbance. Now, the importance of noting this on your paper on the first day is extremely important. Imagine this, an important person with an ulnar nerve problem, which comes to light post-operatively, you're in big trouble. So if you've noted it earlier, it's a good thing. And then you need to follow this and see to it that the ulnar nerve, usually if it's not too bothersome, will cure itself and does not require any further treatment. He is a patient who has a hypertrophic scar tendency, and you can see the entire scar is hypertrophic. But eventually he regained almost complete movement of his hands and a complete recovery of his ulnar nerve. Where will you put your plate? You have to put your plate proximal to the watershed line, because I borrowed this slide from Randy Bindra, because the moment the plate starts creeping up, it's going to start allowing the tendons to rub against it, and you're going to have problems there. So you shouldn't have a very thick plate. This is an Indian plate, and it's a very thick plate. It isn't beveled off. And here's a screw that's sticking out. So there are certain plates that you don't want to use. So choose your implant properly, because otherwise you're already putting your patient at a disadvantage. What do you do for rim fractures? That's closer to the rim, beyond the watershed line, very difficult to treat with plates. With the conventional plates, you can't put a screw into this. So how do you then hold these fragments? So you open, reduce, and temporarily fix these with K wires. The rim fragment sometimes remains unstable because it's basically an injury of the ligament, which has taken an avulsion or small flake of bone. So what you need to do is to take a stitch through the ligament, which will harness the bone and bring it back into position. Run these threads through the plate, through the small holes for the K wires in the plate, and then put the plate on in the usual fashion. Put in your screws, but not through these thin, small, flaky fragments. You're going to anchor that by tying a knot onto the plate securely. So then now you've got all the pieces in place. Leave the K wires in, the wires that you use to hold these in position, the raft wires or the wires that are there that are holding this in position. You can leave them in place, and eventually you'll find that he'll get a very good range of movements. You pull the wires out at about 6 to 8 weeks. Should you cover the plate with the PQ, with the pronator quadratus? It's always nice to do that. And I always attempt to do it. And I know that a lot of people believe that it's not necessary. I believe it's necessary for two reasons. One, it was there for a purpose. And if you can put it back, it's excellent. It is considered to be one of the, dynamic stabilizers of the inferior radial ulnar joint. And if that is so, when you're talking about the distal radio ulnar joint, then when you're treating a distal radius fracture, which has that as a component, why do you want to give away one of the stable points? And secondly, it's a lovely soft tissue cover on which the tendons are going to glide. So it's always nice to put it back. So when you're lifting it up, as you can see here, lift it up with the periosteum in one sheet and leave behind an edge so you can suture it back again, or you can suture it back to the first compartment muscles very gently onto the sheath. This is how it's put back. I went back in to remove plates, and I find my pronator is right there. It's all healthy and nice. That's the implants that have come out, and then I've stitched it back again. So you do not sacrifice the pronator quadratus as far as possible. That's the way I look at it, except when it's torn, of course. What about these? Do you need to go in dorsally? Well, we need to think about that, because sometimes you don't need to go dorsally. You can get this fragment from the volar side. What you need to check is that the articular alignment is good, the radial styloid is fixed, the overlap is minimized, and in the lateral view that the plate hides under the teardrop, that the dorsal tilt is corrected, and the styloid screw is placed perfectly within the styloid. You should have at least 75% of the length of the screw, of the width of the distal radius supported with the screws. And see that your proximal screws, this is where we forget. We are so mesmerized by the distal end that we forget the proximal screws, and you can get tendon ruptures from the proximal screws. So be careful about that as well. Here's a patient who has a predominantly dorsal, tempts me to go in dorsally. Now, it's a very distal fracture. So all the more reason I'm thinking if I go volarly, I'm going to be in big trouble, but there's a volar depression. How am I going to get to that from the dorsal side? So what you can do is take down the brachioradialis, go around and get to the dorsal fragment and have your plate on the volar side. Now here's the same case that's been milked into position. And I've tried to use a rim plate. This is a different animal. It's a little more difficult. It comes in one size. It's a very difficult thing to put in. I think they have a 5-hole one as well. So it's two sizes, too big, so, and not the best profile for Indian bones. But I've used it on occasion quite happily. So you push in your dorsal fragments and pin them down temporarily. Here you don't need to open and fix them down because you're using this only as a temporary wire. So be careful when you drill, and then you can put that in, get your plate there, and you can get a good result. What about the volar spike? We've seen that, and we've seen what Hemant spoke about. Once you get that back in, you should check the length of your screws with what is known as the Hoya view. And the Hoya view will tell you the margin of the radius and will tell you exactly to look for screw penetration. There is a 4-corner concept now. I won't go into details for want of time, but all 4 corners are affected in this one. And this is a combination of the Rickley and Regazzoni and the Melanie classification. And here's one which had all 4 corners involved. And here you can see that you needed to go in dorsally as well. And you need to have these plates ready. So we have a set of small plates ready in our theater at all times so that we can go in and do this and get an excellent result. Not plates for this one. This doesn't look like it needs anything until you look at the CT scan. And then you need to go in dorsally. You need to then build it up fragment by fragment. And you can see the table here. This is the fragment being built up one by one and held there with wires and then punched back into place. And eventually the plate has been placed in place. And this is the last case, completely shattered. Can you use a plate for this one? What are your options? There's no bone to hold. Closed reduction and bridging plate, external fixator, which may require a second procedure. Consider a radiocarpal fusion, or is there another viable option? So what I did was to go in volarly, got some wires inside, got the rim fragments in, bend the wires down like you do for a fragment specific fixation, and put on my plate. And you can see as I tighten my plate, those wires get bent and stuck under the plate, and you get a fairly good articular surface. All pieces back in place, wires safely under the plate, and the pronator quadrate is back in place. And this is his video sent this afternoon at 1 o'clock. Just 20 seconds of this. Excellent dorsiflexion, restriction, a good supination, some restriction of the palmar flexion. That's hardly 20 degrees of palmar flexion in his hand, but he has no problem. It's a year out now. He was operated last May. Good radial and ulnar deviation, as you can see here. Excellent result from a very, very difficult situation. So you have to use plates judiciously. You need to understand where you can use them. You need to understand the restrictions or the limitations of your plate. You need to have additional armamentarium. And you should remember that external fixators and K-wires will come to your aid. Thank you very much.
Thank you very much, sir. Very informative presentation, and you made things look very easy, and especially with the use of plates along with the K-wires for these difficult fractures. Now we go to the next talk by Dr. Pankaj Ahire on complications and treatment of these fractures which have been treated with surgical intervention. And we would take the questions after Dr. Abhijit Vaigakar's talk for the entire session. Over to you, Pankaj, and good evening to you.
Thank you, Ashish. Am I audible?
Yes.
Is my screen seen?
Yeah, Pankaj, it's seen.
Perfect. So, good afternoon, everyone. If you are not as accomplished as Dr. Patankar or Dr. Warrior, each one of us is going to get into some complications, and these are a list of a few of complications. Some might be my own, or many of them who have come to me as complicated cases. So I'm just going to share these cases with you. Any one of us could land in these complications. So let's not belittle surgeons who got there first. Okay, so very unusual for a distal radius fracture after surgery to present like this. Think of common things first. Don't think a volar plate fixation will not give rise to an infection. This was a post-operative infection, one of the high-profile patients again. The volar looked very clean, though, so the primary surgeon kept thinking that this can't be implant-related infection, and then got an MRI done. When the MRI actually showed a medullary canal full of infective material and pouring out dorsally, that's when the infection was proven to be because of the related to the fracture. This was the before the drainage. This was the condition, and you can see the struggle that may have happened at the time of the surgery. You can see multiple holes, and that could be an indicator of the soft tissue status and eventually contamination and infection. This patient needed an implant removal. Fortunately, by the time she was referred, the fracture had already started healing. The cloaca was cleaned and filled with the calcium sulfur granules with antibiotic. And she did well. So pearl number one, accept that there can be a complication. Identify and treat early rather than postponing it till the end. And preferably try and use titanium implants so that you can, if MRI is required, you can get it done. It's very useful to give implant certificates to the patient mentioning the make of the implant and the manufacturer so that we know the MR compatibility. Second case, many years ago, I saw this patient. This is clearly an unclassified kind of a fracture, really. You can't put it in any kind of classification. The surgeon who treated this patient first, you put these were the plates, the locking plates had just come new in the market that time. Obviously, this didn't look like it was going anywhere, and it did not. The plate came off, then the plate was removed, an external fixator was put. The gap was filled with cancellous bone graft, as you can see, and like in many other situations, an external fixator is used as an escape route. It clearly did not work, and eventually the external fixator became loose, and this was the condition that the patient came in. So remember, a good implant cannot compensate for a wrong indication. This was clearly not a great indication for this type of plating. A bone gap in the diaphyseal-metaphyseal region cannot be filled by a cancellous bone. Cancellous bone is for contained cavities. Spanning the joint with a stable implant perhaps would have yielded a better outcome. What I mean by spanning the implant, if you have a comminuted fracture like this, and if you just give a gentle traction to it and allow the soft tissues to stretch out, and then place an implant under the muscles, spanning from second metacarpal across the wrist onto the radius. Depending on the direction of the comminution and opening, you could either slide the plate from distal to proximal or proximal to distal. With this, you could get a good function. As much as 78% of mobility of the unaffected side can be obtained by a span plating. So instead of a comminuted fracture, trying to achieve something which was impossible, knowing the limitations of the implants that you have, understanding the fracture personality, and then choosing the correct method would still give a very good result. The story did not end there. This came as a flail-less atrophic bone ends. Fortunately, there was no infection. However, there was a lot of avascular and sclerotic bone. This is the state that I got in. I debrided this thoroughly and put a large chunk of iliac crest bone graft and put a plate dorsally. And I thought this would go on to heal well. It did, but it did not go on to heal without much hiccups. And over a period of time, as the months passed, the plate kept on bending. And fortunately, the bone won the race. The bone healed before the implant could break. And he continues to enjoy good movement, refuses any further correction. And he continues to visit for some other patients, and he's doing very, very well at the moment. To learn from this, I should have perhaps used a much stronger and a larger plate for his arthrodesis. A vascularized fibula graft, which would give biology as well as support and would give faster healing, would have been a better choice. And I should have had a better splinting rather than just a below elbow splint. Perhaps it needed a good above elbow long arm splint until the union happened, so I would have prevented the deformity. A very simple looking fracture fixed with a very good plate, but somehow the surgeon was not confident of what he did at the ulnar radial styloid. And a K-wire additionally has been put. Remember, this plate has 2 rows of screws. If you are not confident of the fixation of this particular screw, you can always put a second row screw, but the surgeons chose to put a K-wire. Now, there's nothing wrong in putting K-wires. Again, this again shows the perhaps a lot of struggle that has gone through while operating. This is the percutaneous wire. If we are not hesitant putting an incision which is 2 or 3 times the length of the plate to put the plate, but we don't want to place a 1 centimeter incision to put a K-wire, the way Dr. Patankar showed. That's how every percutaneous K-wire has to be put. So this patient had tremendous pain on the ulnar styloid. And when I explored it, the superficial branch of the radial nerve was impelled by the K-wire. And only when this K-wire was removed, she had a recovery of symptoms over next 3 to 4 months. So another pearl, avoid percutaneous wire through a puncture. And you must utilize your implant well. Your implant will provide for a lot of things which you leave unutilized. Another simple looking case, there's nothing to discuss in about this fracture really. Okay, a simple plate put. It was an extra-articular fracture. The plate remained a bit proud, which perhaps I did not even notice intraoperatively. This is my own case. And this patient had tremendous flexor synovitis post-operatively. There were no signs of infection. And I concluded that this was because of the mechanical irritation of the plate. And only when the plate was removed, she recovered out of this. So that was about the flexor irritation. This is another very simple case. Well fixed. The contour of the plate is nicely matching. This is unlikely to give rise to any problem on the volar side. Another case, same implant now has been advanced a little bit, and now the edge starts becoming prominent. This is not what is ideal really. You want a contour of the plate which matches with the contour of the radius, and not a plate which is standing out like this. This is going to give rise to some amount of flexor irritation. So what we need to do is ensure that whenever you are putting an extra articular plate, ensure that you put it at or proximal to the watershed line. There are implants designed to be put at the watershed line, an implant to be put 2 millimeters proximal to the watershed line. This is another example where the implant is put at the watershed line and the implant contour matches very well. So choose the right design of the plate. Simply advancing the plate that you have used before for a more distal fracture will not work. No sharp edge in the gliding part of the tendons, especially flexor tendons. Whenever you are looking at a fracture, there might be fracture areas which may not sit well only with a plate. And if you are not happy with the way this fragment is engaged by the plate, do not hesitate to put an additional screw. The plate design that was put did not have option of more than 1 screw here. This would have been in the fracture. With a newer plate design, I could have perhaps got 3 screws in this, and this would not have been necessary. However, if I don't put this screw, then it's a disaster. You need to address the lunate fossa fragment adequately. Now, this is another example of a lunate fossa fragment. Rohan told you about the teardrop fracture. This is a classical teardrop fracture. The lunate fossa is depressed. If this lunate fossa is not fixed, this will continue to have subluxation postoperatively. So, despite an extra articular plate being used, I knew that this plate is not engaging this fragment very well. I have gone ahead and put an extra screw distal to the plate. This is a screw distal to the plate only to fix that fragment. And when you don't do it, this is what you get, a postoperative subluxation. This fragment completely escaped the fixation. And in such cases, I had to redo the fixation. I advanced the plate to include that lunate fragment, and it is useful to neutralize this with an external fixator for a period of 3 weeks till healing happens. If you do not want to land up in this situation, just like Dr. Warrior showed, very, very distal fracture, it may not be amenable to a conventional plate fixation. So this is what can be done. A plate fixation, there are no screws in the distal fragment, doesn't mean that there is no fixation. There is fixation by virtue of the ligaments. So this rim of the bone with its attached ligaments, there are ethibond sutures that are placed. Ethibond sutures are threaded to the plate. The plate is seated. The threads are tied over. That will give a buttress, and the plate obviously is put in a buttress mode. And this gives a very stable fixation with an excellent end result for the patient. Another patient, comminuted fracture, a completely wrong choice of implant, even worse, perhaps an improper application of the implant. Even with this implant, if this was fixed well, the ulnar fragment was fixed well, this would have still gone on to do well. This patient had DRUJ subluxation as well and came to me with severe stiffness. There was virtually zero movement in the wrist, zero movement in the distal radioulnar joint. This patient underwent a revision fixation of the open repair of the TFCC, and also underwent arthroscopic wrist arthrolysis, and eventually went on to heal well and gain excellent range of movement. So pearls, a lot of pearls. Lunate fossa fragment may need fixation outside the plate. Ensure that you engage the lunate fossa fragment either through sutures or by at least 2 screws. And always address the DRUJ if it is unstable. Whichever way, you could treat it either by a above elbow fast with a DRUJ wire, fixation of ulnar styloid fragment, repair of the TFCC, whichever way, but the DRUJ needs to be addressed. A very poor quality X-ray. This is sent by the patient himself, because these are the X-rays which are sent for insurance purposes. So I did not have access to the original copy. This was fixed by a surgeon, and just like the volar piece, now there is a dorsal piece which has been completely missed. Very unhappy patient, very severe restriction and pain of the pain. This was a CT scan. This is the dorsal fragment which was completely missed. Okay, and intraoperatively, you can see this line represents the cut at the area at which the actual cut has been taken. This is where that gap that you're talking about. So this entire fragment had completely missed the fixation. So we went on to do a dorsal fixation for this patient. We did not touch anything from the volar side except perhaps removal of a screw which was preventing reduction. And this patient went on to do very well. This is the video sent by the patient. And she is doing all kinds of things with the wrist. She plays harmonium. She was very happy to get back to the movements that she had. So another pearl, intermediate column and volar dorsal fragments. In intermediate column, the volar and dorsal fragments may be separate. So whenever you are going volar, ensure that the plate is engaging the volar fragment, and ensure that the dorsal fragment is not completely left unreduced. These are articular pieces to which ligaments are attached, and therefore, just like any other articular piece, it requires anatomic reduction and stable fixation. This is the case which I showed before as well. Yeah, it's a simple looking fracture, and I showed this for the contour of the plate. problem that this patient had was he was extremely active post-operatively, and one day came with an rupture of the EPL. This was the screw which was offending. So a screw which is projecting on the dorsum will not spare the extensor tendons. Far more problems are with the extensor tendon than with the volar tendon, than with the flexor tendons in distal radius plate fixation. So this led to extensor tendon irritation. Not only this screw, as Dr. Warrior said, even this screw. So this is a genuine problem, and you need to not hesitate, remove this screw and change. This was another patient. Another patient which had an extensive extensor tendon rupture because of the plate, and this was one single offending screw which caused all the rupture, and all extensor tendons were ruptured. Went on to, we had to do an extensive reconstruction for her. This is a palmaris longus graft, and we breached the graft, and she went on to have a very reasonable function. So this is what she had, and this is what she got at the end of reconstruction. So it's not the patients whom you can blame all the tendon problems on. We are commonly responsible for them. So another pearl, extensor tendon attrition is more common with volar plates than with dorsal plates. It's the central screws in the distal row of that volar plate which are the culprit. So how to avoid it? I always measure the screw lengths that I am putting. I drill bicortical, measure the screw lengths, and always put 2 millimeters shorter screws than the measurement. If that means not a very good hold on the dorsal fragment, I would add a plaster for 2 weeks. So to summarize, keep infection in mind always. It's a common complication of any prolonged surgery. Know the limitations of the implant, know the limitations of the fractures that the fractures will place on your skills. Percute wires aren't always safe. Please place a small incision, get the nerves out of the way. Prominent plate will lead to flexion attrition. If not tear, it will lead to tremendous stiffness because of synovitis. Choose the implant, correct implant design. Your dorsally projecting screws will cause serious damage. So there is no room of error there at all, not acceptable at all. Your volar lunate fragment may need fixation outside the plate. Even after you have put an expensive plate, you may have to put a small little screw to get a better fixation. And do not hesitate to go dorsal after you have done a prolonged surgery on the volar side. If you are not happy with the reduction of the dorsal fragment, please go dorsally, put a small plate, wire, whichever way you want to get the dorsal reduction. Thank you very much. Enjoy the necklace of pearls.
Thank you, Dr. Pankaj. And I would like to invite Dr. Abhijit Vaigaonkar for his talk on solutions for the fractured ulnar styloid. Dr. Abhijit?
Yeah,
welcome.
Am I audible?
Yes, Abhijit.
Yeah, great. So at the outset, I would like to thank the organizing committee and the ISSH for the opportunity, and especially for addressing less talked about component of the wrist joint, and that is the ulnar styloid fractures. I hope everyone is doing well and is safe and healthy. I have no conflict of interest regarding this particular talk. So we are going to talk about the relevance, the anatomy, and the biomechanics of ulnar styloid fractures. We are going to talk about the classification systems very briefly. There are not many of them. Evidence supporting the neglecting fixation of the ulnar styloid, and evidence supportive of fixing the ulnar styloid, the treatment recommendations and the operative techniques in brief, and the post-op protocol and the caveats when you're dealing with these particular fractures. So the relevance of ulnar styloid fractures exists along with a lot of controversy, and in almost every hand or wrist conference, there is so much of debate that is generated around this small little piece of bone. So almost 50 to 65% of distal radius fractures are associated with ulnar styloid fractures, and they commonly proceed to non-union, and most of them are asymptomatic, but a few will be symptomatic. And it is these cohort or this subgroup of patients where we need to think about some kind of treatment. And ulnar styloid fractures need not necessarily be associated with poor outcomes all the time, and they need not be associated with instability all the time. So we will through this talk, understand which are those fractures that merit fixation, identifying them, and dealing with them. This particular paper by Hawk and Palmer, from which the classification of ulnar styloids is derived, also spoke about symptomatic non-union and the problems that are associated with symptomatic non-union of ulnar styloid fractures. And basically, when the fracture is through the base of the styloid, which is where the TFCC is attached, that is when instability would occur. There may be associated TFCC tears. Non-united fragments may act as an irritating loose body and abut the carpus, and there may be impingement of the ECU sheath. This particular slide shows, this is a cadaver dissection coronal view, shows the components of the TFCC that we now have come to appreciate. So there is a proximal component which is attached to the base of the styloid at the fovea through Sharpie's fibers, and the distal component is more or less a loose soft tissue collagenous structure. And therefore, you can imagine that any fracture through the base of the styloid, which would involve a rupture of the TFCC, so the fragment which is attached to the TFCC would obviously then give rise to DRG instability. And why do we talk so much about such a small piece of bone? What is this controversy? Why is it that we keep on debating about it? It is when we look at the schematic diagram here, and when you look at the DRU as a load-bearing joint, you would understand the importance of the ulna, which acts as a counterforce against the radius when you are doing prehensile movement, such as lifting weights, where a large resultant force is generated at the DRUJ. And you need the TFCC and the styloid intact to go through the complete range of movement, as well as to be able to perform function with a stable DRUJ. The classification is named after Palmer, where you have type 1 and type 2. Type 2 is at the base. It could be a horizontal or an oblique fracture, whereas the distal fractures are those of the tip at the mid portion. And then it doesn't take too much of imagination to understand that the fractures at the base, whether it is horizontal or oblique, which would perhaps result in greater disability from instability of the DRUJ. And this particular slide figure gives you the approximate incidence. The base fractures account for almost 40% of the fractures, whereas the distal fractures are far less in frequency. When you look at DRUJ instability, which is associated with DRUJ fractures, we should understand that 3 to 37% of distal radius fractures may have an associated DRUJ instability. And ulnar styloid fractures, according to Frickman, occurs in almost 60% of patients having distal radius fractures. However, it is remarkable that fewer than 10% of these patients would necessitate some kind of fixation of the distal ulna or the styloid. So let us proceed to the second part of the talk, where we are going to just very briefly go through literature, a few papers that are important. And this particular paper by Sebastian Sauer and Jesse Jupiter and David Ring, this was a multi-center study, which was a retroprospective kind of cohort level 3 study. They had a case control armed, and they studied 132 patients with untreated ulnar styloid fractures, comparing displaced versus non-displaced, more than 2 millimeters of displacement. And they excluded 16 patients from this study where the ulnar styloid process was fixed per the preference of the operating surgeon. And they also took into consideration the ORI for the distal radius. And you can see here, when they compared the contralateral side of ulnar fracture and no ulnar fracture, there was no significant difference in all the parameters between the ulnar fracture and no ulnar fracture cohorts. What is also very important to note is that there was no difference in the flexion at 2 years, no difference in ulnar deviation at 2 years, and no significant difference in the grip strength at around 2 years. So in all their parameters that they looked at, right from the dash scores to the range of motion to the grip strength, and they looked at the Gartland and Verdi demerit system, you can see that they have almost similar outcomes. And they concluded that unrepaired ulnar styloid fractures, there is no clinical difference versus no fracture in the setting of distal radius fractures, undergoing open reduction internal fixation. So this particular study then perhaps brings to mind the study that was undertaken and reported by Mark Ross from Australia. So there must be other factors other than the styloid process that contribute to DRUJ stability. This particular slide is a drawing which shows the distal oblique band of the intraosseous membrane. And when the proximal fragment is medially displaced, it is imperative to reduce this peak that is caused and thereby retensioning the distal oblique band and thereby stabilizing the DRUJ even in the presence of an ulnar styloid fracture, and that would therefore result in a stable DRUJ. Another study from Japan, it was a retrospective cohort of about 118 patients, and they underwent volar locking plate, and no ulnar styloid fractures were treated operatively. And when they looked at their results, they concluded that ulnar styloid wrist pain improved gradually with time, and there was no significant difference in the incidence of ulnar wrist pain between their groups, where they had 3 groups, no fracture, control group, and where they had a base fracture and a tip group. And they concluded that there was no relationship between ulnar pain and the union of the ulnar styloid fracture. Another study by David Ring had almost similar kind of observations, and they did not immobilize the DRUJ when they had a good reduction of the distal radius fracture and fixation. So all of these studies are in favor of not fixing the ulnar styloid fracture, and you see why. When you have a when you have a distal radius fracture which is fixed well, restoring all parameters, the DRUJ lends itself to being stable without the need for fixation of the ulnar styloid process. So another study from Douglas Sammer and Kevin C. Chung, here they looked at the Michigan Hand Questionnaire, and they concluded that with a stable DRUJ after distal radius fracture, which has been fixed and all parameters have been restored, regardless of the ulnar styloid fracture size, the degree of displacement, or the presence or absence of non-union, their patients went on to have good outcomes. So I'll just kind of rush through these slides in the interest of time. So the summary thus far has been that after ORIF of the distal radius, there is no difference in outcomes when you compare ulnar styloid fractures versus those who have no fractures, and there is no difference when the TSCC fixation and immobilization has been done for Frickman type 2 and 6. Let us look at a couple of studies that prove otherwise, which are in favor of fixation of ulnar styloid process. This was a study from Cleveland from Philip Blazar's group. They did a retrospective review, and they found that ulnar styloid fractures that were displaced by more than 2 millimeters and were not addressed and had DRUJ instability went on to have poorer outcomes in terms of stiffness of the wrist joint, relating to loss of movement and ulnar styloid wrist pain. And therefore, they recommend fixation of the ulnar styloid fracture if it is grossly displaced. Another study from Tommy Lindau and the Swedish group, it was a prospective study where they looked at the distal radius fractures along with ulnar styloid fractures, performed diagnostic arthroscopy for distal radius fractures, and DRUJ instability was determined by clinical examination, and all unstable fractures lend themselves to a poorer outcome on the Gartland-Verdi score. So they concluded that in their study, where people had instability of the DRUJ on clinical examination, they had worse clinical outcomes and pain scores were worse. So this begs the question, if Shakespeare were to be alive today, he would have perhaps asked to fix or not to fix the ulnar styloid. And what are the recommendations? Ulnar styloid fractures require fixation or stabilization when they are the cause of DRUJ instability, either partly or wholly. And how do we determine that? We determine that by examining the DRUJ stability after you have fixed the distal radius fracture in 3 rotations and comparing it with the opposite side. And if you find it to be unstable, you should first ask the question whether your distal radius fracture has been adequately fixed with the restoration of all normal parameters, and then you would proceed to stabilizing the styloid. Here is a Here is an example of a distal radius fracture. You can see that there is an ulnar styloid fracture. And when we had fixed the distal radius, we examined the DRUJ and found it to be stable. And therefore, we just chose to neglect the styloid fracture. And this, my patient went on to have good outcomes. So if stabilization is deemed necessary, multiple options are available. The fracture configuration will dictate your choices, and the fragment size will also beg the type of fixation that you would opt for. And in general, or if you were to kind of have a rule of the thumb, more distal and comminuted fragments are usually suitable for reconstruction by soft tissue reattachment by ignoring the fracture fragments, whereas basal fractures of the ulnar styloid might require some kind of fixation. And there is a litany of options that are available out there. You may use suture anchors, you may use tension band wiring, you may use screws of different types, a headless compression screw, a small fragment screw, and this particular plate, which has been recently introduced by Arthrex, I have no conflict of interest with this particular slide. So this particular implant also will give you a good fixation, especially if there is a fracture of the head of the ulna associated with the styloid fracture. So the caveats, like Dr. Sudhir Warrior showed us, did not injure the sensory branch, the dorsal sensory branch of the ulnar nerve, avoid splitting the styloid fragment, do not use excessive hardware, do not detach the TFCC attachments to the styloid, and avoid opening or elevating the ECU subsheath, because the ECU subsheath forms an extremely important stabilizing element of the DRUJ. Postoperatively, we usually begin with a long arm splint, which is converted to a long arm cast, and at around 4 to 6 weeks, that is converted to a well molded short arm cast, and then a removable splint with graduated physiotherapy program. So in conclusion, recovery of stability, motion, and strength is consistently achieved in most of these fractures. Outcomes do not correlate to the bony union, and fibrous union is often adequate, but there is a small cohort of patients that would beg fixation. We need to identify them with examining the DRUJ in 3 rotations, comparing with the opposite side after you have fixed the distal radius fracture. And with that, I wish you well, and thank you very much for the opportunity to speak here.
Thank you very much, Dr. Abhijit. And
thank you.
So if I can request Dr. Patankar, Dr. Warrior, and Dr. Aire to unmute themselves, there are a few questions that have come on the screen. And one of the questions to Dr. Patankar is that when you're removing the wires which have been put antegrade, do you remove them all at one sitting, or is there a possibility that you could remove them on 2 sittings?
Actually, the way the wires are cut, there is no need to remove any wire formally.
Okay.
Only if the patient has some issue with that, then only you have to remove the wires. The wires have been cut and bent very carefully. Even in the child which I showed, he has now become a doctor. I think he's an intern now, medical intern, and he has not yet come for wire removal. And he does not have any problem. He must have definitely developed an adventitious bursa, but that's not giving him any problem yet.
Okay. There's a question to Dr. Warrior, is that what is the role of tenotomy of the brachioradialis?
I did show one case when you need to go to the dorsal aspect, when you're dealing with a delayed fracture where the brachioradialis may be tight and you want to release the fragment. These are the 2 instances where you would do a tenotomy. You may or may not do it in a Z fashion. You can just leave it by doing a transverse tenotomy.
Okay. So I think those were the questions that we received on our chat, and in interest of time, I think we would proceed to the next session, and I would like to hand over to Dr. Pankaj Ahire to take us over through the next session.
Thank you, everybody.
Thank you.
Thank you.
Give me a moment. Thank you, everyone, for a wonderful session. Abhijit, we would perhaps have questions for you, which might come up later because there is a certain amount of lag between the live transmission and our Zoom meeting. So we now start a session on carpal injuries, and we have a fantastic group of speakers for this. And to open the session, may I invite Dr. Anil Bhatt, Professor and Head, Department of Orthopedics at Manipal. He's going to speak to us about approach to proximal pole of scaphoid fractures, acute as well as chronic fractures. Anil, over to you.
Thank you, Pankaj. Am I audible?
Yes, sir.
Okay. Yeah, thank you. I'll be basically speaking on acute fracture of the scaphoid proximal pole. Parag had asked me acute or chronic, actually. So in 8 minutes, I would like to cover the acute ones. If you actually look at the literature, there's hardly any much papers actually talking of acute proximal pole. So I thought I would go through that completely. Now, if you look at these three fractures in our body, the fracture neck of femur, or the talus fracture, the talar neck fractures, or the the scaphoid fracture per se, and all these are the troublesome ones. And we always know that all these fractures, or rather the areas, receive the blood supply from distal to proximal. And when there is a fracture along any of these things, the proximal portion goes for trouble, which basically means it might go for a vascular necrosis, and the fracture per se will go for non-union. And I feel that God created these special areas just to develop our surgical skills and get in with more and more types of discussions in these webinars. Now, if you look at the proximal pole fractures itself, most of the papers give about a very low incidence of 6 to 20%. Even in the large series of scaphoid fractures, the incidence or the numbers will be always very, very less of proximal pole fractures. The other problem here is the union times generally stretches between 3 to 6 months. I'm talking this about most of early series, which of conservative kind of managements, and not the aggressive kind of approach we have now. And a lot of them were actually basically X-ray followed up series. So it's nowadays better evaluated with CT to see the earlier unions. The non-union incidence ranges again in literature. If you see the papers from 15 to 50%, on average, you can take about 30% and tell people, our patients, that average they can go up to 30% of a non-union kind of incidence. Fracture displacement of fracture translation, combination, cysts, or delayed treatment, patients seeking treatment later, smoking, advanced age, and avian per se are the risk factors for these. Now, again, went through the literature for actually defining what is proximal pole, and right from this standard definition in some of the books where they say less than 33% of the scaphoid length on a PA radiograph in ulnar deviation, complete ulnar deviation is probably proximal pole. There's one Schoenberg's classification. I think it was basically used as a French literature. Basically, even the paper is in French actually. And this is probably was used for the non-unions, and they say, and rather he says that proximal pole is zone 1 and zone 2. I couldn't make out exactly how they drew this areas or boundaries, even though I read the paper. And there's a group from Joseph Dials, and they go even more further. They say the proximal fifth is probably the 20% is the proximal pole, and that's probably cutting too close there. A lot of us see these proximal poles somewhere here. Moment we see a fracture line somewhere here, we think it's proximal pole, and somewhere near this bend here is actually the waist of the scaphoid. Now, very classical young patients, usually with the history of fall, hyperextended wrist, radial sided pain. These are the ones which come. Sometimes they come late because not much of swelling, not much of pain. And possibilities of radial-sided pain to be kept in mind would be obviously distal radius, scaphoid, scapholunate, and CMC injuries. And if you look at scaphoid, the way it lies, actually it's a big bone there, right? And it's spanning both the proximal and the distal rows, and it's a big bone. So if we classically just examine anatomical snuff box, we might miss the fractures here and here. And I keep always insisting that always examine the 3 parts of the scaphoid. And for the proximal pole is basically on the dorsal aspect. Your listus tubercle is like your lighthouse, and you need to follow that. The moment you go distal to the listus tubercle, you get the radiocarpal joint, the sulcus just above finger breadths there. You'll feel a dip here, and the prominence there is a scapholunate kind of a junction here. And or including the scapholunate ligament tenderness could be there, or if you just go radial to this, you will feel the proximal pole of the scaphoid. So you're from your listus here, somewhere here, you're going there, and then you're feeling this. It's very important to check for these clinical tenderness. And X-rays, again, the full series of X-rays is required, PA, ulnar deviation, lateral, and obliques also. And in a lateral, basically, you're checking for any amount of carpal instability, especially if there is an injury somewhere here with a fracture somewhere there with the scapholunate kind of injury, and you might get a TC kind of deformity. You need to be checking on that. CT, ask for 0.5 to 1 millimeter. We're going at very small place here, and we're looking at very tiny displacement. So you might have to go to 0.5 to 1 millimeter cuts in the axis of the scaphoid, and then you see all the views, you reconstruct that, and then probably you might find the fracture line in one of these things. So it's very, very important. And then definitely MRI for early diagnosis is always the second line of investigation. CT helps you to see the fracture line, the combination, and helps you to plan your treatment. Now, once the fracture is diagnosed, what decides non-operative management? Who decides? When I say who, is it the patient or you? Sometimes it's important, especially in this. And for surgery, what are the determinants and what is the method of the implant? And for scaphoid per se, stability of the fracture, location, and patient factors are very, very important for you to treat them. Now, if you go through the Herbert's, all proximal pole fractures, straight away Herbert says that it is unstable fractures. The B3 kind of fractures are definitely unstable fractures. So that's what it's straight away put into it. But if you see overall, again, by Cooney stability factors, more than a millimeter displacement. This is for most of the waist fractures, intrascaphoid angle, bone loss communication, sorry. But again, he says proximal pole, again, everything is unstable. They're all very unstable fractures. DC alignments, perilunate fracture dislocations, these are all these are all stability factors. Proximal pole per se, why it is unstable? Very tiny fragments, small fragments, right? And then there is a tenuous blood supply. We all know about the blood supply. Intra-articular location bathed by the synovial fluid, so it has got its own problems. The long lever arm stress at the fracture site here, and then the secondary carpal instability which can ensue with this. So all displaced or undisplaced proximal pole fractures inherently are quite unstable. Now, the role of cast, if you see these outcomes here, the original earlier kind of series, almost the union rates are just about 70%. And casting time to go almost 9 to 20 weeks. So I think if somebody wants a cast, leave the decision to the patient themselves. You should not be you should be pushing them probably towards a surgery in this kind of a situation, because we know the problems. But if patient insists that not having a surgery, you will have to leave the decision and tell them that the union rates are just about 70, and compared to a fixation which is more than 90, and then long casting times of about 9 to 20 weeks. Right? Both short and long arm casts have been used in these series, but generally this is the incidence of non-union, right from 15 to 50%, as I told earlier. With an average, you can take it as 30%. Now, since the advent of percutaneous technique, more aggressive approach towards the fixation, but definitely there are no RCTs to compare both the methods, cast versus fixation, probably an option to explore for us in future studies. Surgical treatment, dorsal approach gives the direct access for the proximal pole. With the percutaneous technique, you can use an arthroscopic assisted kind of a technique, a mini open technique. These are the ones. Implants, keep everything ready. K-wires definitely might help, especially with tiny fragments. Headless screws and suture anchors are required. Now, a headless screw, the trailing diameter is very, very important. So you need to see what is the diameters here and what goes through the fracture site, right? And so if you're going from the dorsal side, this area becomes a trailing diameter, and your basic aim is balancing of attaining the secure fixation while minimizing the risk for any heterogenic combination there. So that's very, very important. You might splinter the tiny fragment there when you're putting in these screws. So which means that if we don't have these right kind of size screws, and we don't really get these mini and micro screws, I think it's not yet available here. So it becomes very, very important to have this. Again, we don't have morphometric studies in Indian scaphoid, so we don't know this. But then the Western literature says about 3, kind of that is the 3 millimeter kind of a figure which they put. So your trailing thread should be less than 2.8 millimeters for it to go there, and fragments less than 20% of scaphoid area will require these mini screws or the micro screws, which are available in some particular sets. Now, dorsal percutaneous approach popularized by Slade, screw can be placed in the central axis. You can visualize the scapholunate ligament if you're doing a mini open. But the only problem is wrist needs to be hyperflexed. So what happens is that can displace the fracture to create a kind of humpback kind of a deformity. There's a way to do a percutaneous fixation. Now, if you flex the wrist, hyperflex the wrist like this, what you see, and I use a 14 gauge kind of a sleeve here, which can be used as a drill guide here actually. So when you hyperflex it and see under image, you would see the overlap of the distal and the proximal pole, and that is your central, that is your entry point basically. So that is the entry point. If you can get it accurately percutaneously, it's good enough. And once you got that, then you have to use, you can use this drill sleeve like this, and then the drill guide goes in through this in this way. And then you need to come out on the dorsal-radial aspect here, because you can't extend the wrist with this. So you have to come out here and then withdraw this wire back here to be in flush at this point here. That is the time you can actually, extend the wrist and take the true lateral views for you to check whether your guide wire in the central place or not. And once that is done, you can have an additional, wire as a derotation kind of a thing, and then the screw can go in. Like this, from dorsal to from the proximal pole towards the distal pole like this, and check your again oblique and lateral views, and that's how it goes. Now this is a series which shows micro screws used for very tiny fragments like this, showing that the trailing diameter is very small and it can hold on to these fragments. Now, if you don't get that percutaneous technique, the center point for your drill guide to go in, the guide wire to go in, you can make a small mini opening here. There's no problem with that. You can just visualize the proximal pole here and see the scapholunate ligament also. And then the steps are the same. You use the drill guide like this, you measure, right? And then you put in the screw there, and a tiny amount of cartilage defect would be there, like would happen in any kind of scaphoid fixation. That is the way open reduction is done, a very formal open reduction. You can, if it is displaced slightly, you can reduce it by joystick. This is not proximal pole. I'm just giving an example of a waist like this. So it's displaced, and you put in 2K wires like this, and then try to get this. So once you put in into the distal pole and the proximal pole, you need to get this. The distal pole comes towards the ulnar side, and this goes towards the radial side, and then you can align them nicely, and then you can go through a percutaneous technique. But this is for the waist. This is not a classical proximal pole. Arthroscopic assisted, my teachers have always taught that, especially all these areas which I showed you initially, talus or fracture neck femur or scaphoid, if they come a little late, as in they are untreated, and they by 3 weeks it has to be treated like a non-union. Okay, so that is the aggressiveness we need to have. And now we have an option with an arthroscopic thing. Even if the patient comes late by about 3 or 4 weeks, you don't really have to open up them, and with an arthroscopic kind of an assistance, we can actually, these are the mid-carpal portals. I'm going in there, and you can see that's the capitate here. That is a scaphoid. You can see the fracture site here, and you can debride that fracture site nicely, take off all the fibrous tissue here, and freshen the edges, and then you can go in and do a percutaneous kind of fixation. So you can remove that, freshen the edges, get the fresh bleeding, and then again you can go into the. So it's just an additional skill, an additional technique. I'm not recommending that it has to be done like this, but just an option for us to remember this. very, very tiny proximal pools of scapholunate injuries. These should be not missed. No, very tiny fragment here. And then there is a gap here. Scapholunate injury is definitely there. And probably a fragment excision is worthwhile in this. Probably this is the only indication. Otherwise, we should not be excising this big proximal fragment fractures, very small fragments like this, and then you can repair this scapholunate to this directly using a suture anchor. So that's one of the options. So these are different scenarios and different treatment options you have for the proximal fractures. So there is low incidence, luckily, and then they're inherently unstable. That's what we need to remember. Patient decides on conservative approach. We don't really recommend cast application for a proximal pole fracture nowadays. Percutaneous technique causes the least vascular disturbance. Mini open technique is a good alternative, and complications, non-union and avian require a combination of strategies. I mean, that's a huge chapter again, the moment it goes into non-union and avian, how to recognize that, what is the role of MRI in today's world. There's so many things which we can discuss, but I think for an acute proximal pole, this is the basic approach which we follow. Thank you so much.
Thanks, Anil. Stay online. You might have some questions. Our next speaker is Dr. Amit Warade, and he's going to speak to us about choice of grafts in non-union of the scaphoid. And while Amit gets his presentation running, there's a question for Abhijit Vahegaonkar. Abhijit, come back.
Yeah, I'm here.
Yeah, so there was a question for you. You may have answered it in your talk, but I think it would just help to summarize when and how to repair TFCC tears which are associated with distal radius fractures.
Okay, good question. So it has been seen that almost about 53% to 55% of extra-articular fractures and about 35% of intra-articular fractures are associated with some kind of a ligament injury, more so the TFCC. Again, once you have fixed the distal radius, you would want to check for instability of the DRUJ in 3 rotations: mid-prone, neutral, and supination, regardless of the ulnar styloid fracture or a distal end ulnar fracture. Now, if the DRUJ is stable in supination and mid-prone, but unstable in one direction, that is usually dorsal, in the pronated position, and you compare it with the opposite side and you see that there is pronation, there is instability, you would immobilize in an above elbow cast or a split. However, if there is instability of the DRUJ on antero-posterior translation, even in supination, then you would consider repairing the TFCC. This may be accomplished either by an arthroscopic method, either by a mini open or an open method using suture anchors. If there is a large bit of the ulnar styloid process which is attached to the base, then you would fix that ulnar styloid process by any of the methods. So I hope that answers the question.
Yeah, thanks, Abhijit. Yeah, is Dr. Warrior online? Dr. Warrior, are you available to answer a question? Believe not. Dr. Patankar, are you available to answer a question?
Yeah.
Yeah, the question is, if there is a radius fracture, isolated radius fracture, and there is another case of a similar anatomy of the fracture, but with an extra-articular fracture of the ulna as well, ulna neck fracture. So would your choice of treatment be different for these 2 cases?
Can you just repeat the question, please?
Yeah, so if you have a distal radius fracture, isolated distal radius fracture, and you have another case of a distal radius fracture with an extra-articular fracture of the ulna as well, it's a very distal ulna fracture. So would your choice of treatment for the distal radius fracture be different for these 2 cases? One in which the ulna is intact, the second one in which the ulna is fractured at the neck.
Yeah, in fact, if the ulna is fractured, then more the chances that the close reduction will succeed and both the bones will collapse together and there won't be any problem with forearm rotation. My main concern with treating distal radius fractures is forearm rotation. I'm really not bothered about the wrist function because that they will always, patient will adapt themselves. But if there is a distal radius fracture on its own without the ulnar fracture, then it is important to equalize the lengths and ensure that there is no problem with forearm rotation.
Okay, so you would feel that the ulna extra-articular fracture is a blessing in disguise.
It's always a blessing in disguise.
As far as the DRUJ is concerned.
Yeah, yeah.
Yes.
They collapse equally. They collapse together. So there is no problem.
Yes. Thank you, sir. Anil, question for you. For proximal pole non-unions, would you consider K wires as better implants than screws, given that they would be atrophic, sclerotic, hard, and brittle?
Well, I've not gone to the non-union part of it. Now, non-union again depends on how much of fragment you have. What's the status of that? How do you define an avascular necrosis versus an ischemic fragment? There's so many things. You have a sclerotic kind of a thing. You have a just a fibrous kind of a thing. You have, cystic kind of thing. So there are so many things. At the end of the day, what you require is that has to unite to the main fragment, that it has to be vascular. So I think just one aspect of a K-wire might not come into the picture here. I would use whatever implant possible to hold that back to the main fragment. If it comes to K-wire, yes. If it comes to a screw, yes. But whatever it is, at the end of the day, the biology is more important compared to the mechanical part of it here, especially in the proximal fragment. And sometimes even the K-wire is a big bailout for us. In these tiny fragments, if you have the right instrument,
between the two, what would you feel safer with?
No, if I have the right sized implant in terms of a screw, I would definitely.
So you are more comfortable using the screw if you have the right size one.
Correct. Like okay. If you have a micro or mini, Patankar sir is laughing there, but then. But if you have those right size implants, definitely you can go for that. There is no, I'm not talking of compression here. It is just, yes, it is not about compression here at all. It's just about spanning the whole segment as a single segment now for me, that for the tiny fragment to go back to the main fragment, right?
So we'll have
using a vascularized graft, maybe a K-wire would be better compared to if I'm using just a cancellous graft, I might still use a screw. Yeah.
Sure. We'll just have Dr. Patankar make the final closing comment on this, and before we move on to Amit's presentation.
Yeah, actually,
K-wire or screw?
K-wire, because the problem is that some of the proximal poles are so small. I feel always very scared of, or I would say, shattering them with putting a screw. And I would like to always put a retrograde K-wires. And I think I have seen that by just stabilizing them with a retrograde K-wires, you can really put 2 1 millimeter K-wires and the fracture gets very nicely stable. My main fixation is going to be a plaster. I'm not going to be, as you said, you are going to use a screw for stabilization and no compression. So K-wires give better stability. And I think that the central axis placement and offset or oblique placement of the screw really doesn't matter. That's my experience. I am sure your experience is different.
Anil, we'll come back at the end of this session. Before we move.
Just a comment made last time also, to Patankar sir only, that it's finally the archer and not the arrow.
It's a sharp arrow, but.
Yeah, but he says blunt arrow won't work. Yeah.
Yeah.
Hello.
Of scaphoid fractures.
Hello. Am I audible to all?
Yes, perfect.
Yeah. Good evening, and thank you, Parag and team, for giving me this opportunity. I'll be talking on choice of graft in non-union of scaphoid. Scaphoid non-union is scaphoid fracture diagnosed 6 months from the time of injury or the time of treatment. It is a failure of non-operative or operative treatment for acute and subacute scaphoid fractures. We order this set of X-rays, X-ray PA view of the wrist in ulnar deviation, lateral view, oblique view, and elongated view of the scaphoid. X-ray is basically to see the site of non-union, whether it is at the proximal pole, whether there is a west non-union, or whether there is a distal pole non-union. On X-rays, we can also see humpback deformity when lunate is extended and distal pole of the scaphoid is flexed. MRI is basically to see the proximal pole non-union, and we have to order contrast enhanced MRI. But even with contrast enhanced MRI, there is failure to detect 23% of the patients. And according to this paper, many cases diagnosed as having AVN may actually have had satisfactory vascularity of the proximal pole. So what do we do? So best tool to assess vascularity of the proximal pole of the scaphoid is to see intraoperative punctate bleeding by releasing the tourniquet. If there is no bleeding from the proximal fragment, it means that it is avascular. CT scan is mainly to see displacement of the fragment, humpback deformity, and comminution of the scaphoid. And whenever we treat these patients, our aim should be restoration of the length, restoration of the alignment by correcting carpal instability to achieve stability and compression, and ultimately to achieve union of the scaphoid. Approaches for west and distal pole of the scaphoid non-union, we prefer volar approach between FCR and radial artery, divide the radioscapulocapitate ligament and approach the scaphoid. In case of proximal pole non-unions, we have to go by dorsal approach between the EPL and EP first and third compartment. Then when we treat these patients, after thorough curettage and debridement, after thorough curettage, we have to put bone graft. So available options are non-vascularized bone grafts, Matisse technique, modified Matisse method, and Fisk-Fernandez method. In Matisse method is basically using cancellous bone chips, and it is particularly useful in non-union without humpback deformity and carpal instability. In modified Matisse method, cancellous graft face each other and cortical graft lie on either sides, because it also serves as a mechanical stabilizer of the non-union. In this patient of waist non-union of the scaphoid without deformity, it was approached from the volar side between FCR and radial artery. A S-shaped incision was made on the capsule, and now we can see the gap at the non-union site. It was curated till we can see good quality bone and cancellous bone. It was filled with cancellous bone graft and fixed with Herbert screw. At 4-month follow-up, the scaphoid got united nicely, and patient has got reasonably good range of movement at the wrist joint. So role of bone graft in case of scaphoid non-union is to promote union of the scaphoid, but it is not only that, it is also for restoring normal dimensions of the scaphoid and carpal alignment. See, in this case, when there is humpback deformity, proximal pole of the scaphoid is extended, distal pole is flexed, lunate is looking back. So we call this humpback deformity. So it is important to correct this deformity, because persistent DC deformity disturbs normal kinematics of the wrist and decreases movement, and further it causes arthritic changes. So for such patients, we use Fisk-Fernandez method. This is a very good method. Here, we have to go by volar approach to correct the DC deformity, correct the humpback deformity, and put wedge-shaped graft from the volar side. So this is the reduction maneuver in reduction maneuver. First, we have to flex the wrist. When we flex the wrist, it flexes the extended lunate. Then put radiolunate K-wire. It is a temporary K-wire. Then extend the wrist. When we extend the wrist, the distal pole of the scaphoid get extended. And on the volar side, there is gap is created on the volar side, and the non-union side got open up. So then we have to measure it and put wedge-shaped bone graft. So here in this patient, with the arrow, we can see humpback deformity. And after opening up, this wedge-shaped graft was put in there, and the deformity got corrected. So this is the this patient had non-union since 3 months with a humpback deformity and displacement. So this is the immediate in this method we did Fisk-Fernandez method and put wedge-shaped bone graft. This is the immediate post-surgery X-ray. We can see bone graft at the non-union site, and same patient after 5 months it got united nicely after removing K-wires, and he had also achieved fairly good range of movement at the wrist joint. So another option for scaphoid non-union is vascularized bone graft. As said by Judith, dead bone added to dead bone will not produce live bone. So in case of proximal pole, avascular non-union of the proximal pole, vascularized bone graft is the treatment of choice. So available options are pedicled graft and free graft. Out of pedicled graft, Zeidenberg's graft is very famous. It is based on 1-2 intercompartmental suprareticular artery, and other Matholin and Harley's graft is based on the pedicle from volar carpal artery. And free graft is from the medial femoral condyle. It is popularized by Professor Doi. So you see this is the Zeidenberg's 1-2 ISSRA bone graft. Here, bone graft is taken from the dorsal side of radius based on the recurring branch of the radial artery. And so we see in this case, this patient had a non-union of the proximal pole since 3 months. Then it was approached from the dorsal side. We can nicely see the exposed scaphoid non-union site. Then this graft was harvested from the dorsal distal radius, and after releasing tourniquet, it was bleeding nicely. It was fit into that non-union site and fixed with the K-wire because the size of the proximal fragment was very small. So this graft is a very good choice for avian of the proximal pole, but it is not a good choice for waist non-union, as pedicle length will not reach there. And it is also not a good choice for waist non-union with humpback deformity, as it will require bigger size grafts. Medial femoral condyle free graft. This is a study by Professor Doi, and this is basically a microvascular procedure where we put free graft in the scaphoid non-union. It can be used for avascular proximal pole and waist non-unions. It has sufficient amount of cortical and cancellous graft to create a wedge for correcting deformity in waist non-unions. It should be reserved for failed waist non-union cases. Volar radial artery based graft. Here, the graft is taken from the medial part of the radial epiphysis and vascularized by the radial branch of volar carpal arch. This Professor Matholin and Harley has an extensive study to find out the course of the artery and the dissection method of this graft. And they are using this graft for waist non-union also, because they say scaphoid heals early if we are using vascularized bone graft. So take home message is properly done X-rays are required for diagnosis and decision making. And in case of scaphoid non-union of waist without instability, cancellous bone graft and stable fixation should be done. But whenever there is instability, we should use Fisk-Fernandez method, where we put waist-shaped bone graft into the humpback deformity and correct it. But in case of avascular necrosis of the proximal pole, vascularized bone grafting should be preferred. I thank you very much.
A few questions have come up. Dr. Patankar, there's a question for you. Are you available? Yes, thank you. If there is stiffness after X-fix, if you have used X-fix for treating distal radius and there is a stiff wrist, how would you deal with that stiffness?
There is a stiff wrist. Yeah, if it's an intra-articular fracture, the wrist is bound to be stiff. As I've said, I'm not really bothered about a wrist or the radiocarpal joint stiffness. I'm more interested in regaining painless forearm rotation, hand mobility, shoulder mobility. The wrist will take care of itself by therapy and splints.
Yeah. So extensive therapy, even after the fracture has healed, is your recommendation?
The wrist will eventually come up to a certain range. I'm not sure, or I'm not hopeful that the wrist will move completely, because there is always a mid-carpal joint which is going to compensate for the whole thing.
And
for intra-articular comminuted fracture.
And if you're using an external fixator as a definitive method of treatment, as you showed in a couple of patients,
yes,
how would you prevent stiffness? You said you said how will we treat one, but how would you prevent one? Are there any tips?
Stiffness when the fixator is on. I have to think of wrist stiffness only when the fixator is off. So, and when there is an intra-articular fracture, as I've said, my priorities are different. My priorities are not the wrist. My priorities are the hand and the forearm. So, wrist, I will eventually go for splinting and therapy.
Yes, and one of the recommendations in literature about external fixator has been that whenever there is a over distraction because of external fixator, that is what leads to a lot of radial stiffness. And one of the ways to assess is the fingers have to be able to move through through their complete range of movement when the external fixator has been put. And if you do so, in those cases, the post-operative
Yeah,
stiffness
agreed.
is
But
likely to
in
be less. Yes.
none of my cases, I've used a distractor.
Yes.
All the cases where I showed, the wrist was manually reduced, manual traction was given, and this Fernandez clamp, the rod to rod clamp, is clamped after the position is acceptable by close reduction or
Correct.
keeping it under the C arm. So we have not over distracted. I have never used a distractor in this.
So good point. External fixator does not necessarily mean distraction. It is a static method of achieving what you
Was a
achieved
static
intraoperative.
fixator. In that particular position, the advantage of this AO type clamps is, and this rod to rod clamp, is that you can really get whatever desired position, ulnar deviation, flexion, with these clamps. You can't get it with these SQLF clamps or the UMEX or JES.
And if you are using a slab as a method of external immobilization after you have done a K-wire fixation, what's your choice? Is it a volar slab or a dorsal slab?
Always a dorsal slab. Keeping there, I use generally two slabs. One is a POP slab for the forearm on the table. So I just set it, get it to set, and so that the whole construct should not become very heavy, I use a above elbow slab going up to the forearm, not up to the wrist, which is made of articast or synthetic material. So the thing becomes not very heavy.
Okay. Okay. So it's always a dorsal slab.
It's always a dorsal slab.
Okay. Dr. Warrior, there is a question for you. If there is a fracture with a pure intra-articular depression, okay, without a break in the cortex, I would consider this to be a hypothetical situation, but predominantly an intra-articular depression, how would you elevate this?
I'll have to think of new ways of doing this, because it seems highly improbable, like you mentioned, but there was a situation almost like what is being asked, which I showed, that if you saw that X-ray only and didn't see the CT scan, you wouldn't know that there was a depression. I showed them X-ray and I said, there's no need for a plate for this one until you see the CT scan. So that's probably the kind of case that the person is referring to. It's highly improbable that there'll just be a depression without a cortical break. There has to be some cortical element that breaks off from one lip or the other. I would try and identify that lip, go in from that side, elevate the fragments, and then place in some, if it's a severe depression, maybe think in terms of putting in some grafts, but otherwise have some raft wire and then put in a plate and fix it down. But it will need to be, the lunate will have to be lifted out, the scaphoid will have to be lifted out so that the surfaces are good enough to move again. But really, haven't faced the situation, can only think.
So there would, in all probabilities, there would be maybe an undisplaced rim fracture with a central depression, and you would not hesitate going through the rim fracture to elevate this.
Absolutely.
You would not want to make a window in an intact bone anyway.
For the PIP joint, we talk about that to disimpact a fragment, yes, but not in the distal radius. Very often in the distal radius, you do see depressions, but it involves one rim or the other, and you can actually joystick them back into place.
Okay, and before we move away from distal radius to perilunate injuries and kin box, one final word about the ulnar styloid from Dr. Warrior and then Dr. Patankar and then Anil. Just a few seconds because we are running out of time. Ulnar styloid, when would you fix? When would you not fix?
Well, Abhijit went through a lot of literature.
Yes.
And he presented both sides, and that's just where the world is. And I can't.
What's your choice? You have to make a choice.
Yeah, I can't be very.
What's your protocol? We want to know what's your protocol.
Well, it's a secret. But the thing is, there are 2 or 3 points that I would clinically use See, any fracture that involves the sigmoid notch. So any fracture of the distal ulna or radius that involves the sigmoid notch, I will fix. There's no question about that. So I want the sigmoid notch because, as Hemant said, you need the forearm rotations. Therefore, both sides of the sigmoid notch, that's the ulnar head as well as the radius face, both of them need to be in perfect condition. So that's one thing that's out of the way. Flake fractures, that is just the type 1 ulnar styloid, I would probably not fix. It's the type 2 fractures that usually, when they are displaced, complete styloid, displaced even after I replaced the radius and clinically examined it to find that it's unstable far more. Normally, there is 9 millimeters of play in, once you rest the elbow, there's at least 8 to 9 millimeters play in the ulna. If it's much more than that, and compared to the opposite side, I would think in terms of at least immobilizing the distal radioulnar joint for 3 to 6 weeks. Which ones would I fix? Primarily, there are oblique fractures. These are known to be the worst fractures. The oblique fractures, those are the ones I probably think in terms of fixing. Or if it remains displaced and doesn't come back into place, those are the ones I would think in terms of fixing. I probably may be fixing 3 or 4 ulnar styloids in a year out of about 60 odd fractures, 60, 70 fractures that I might be fixing in a year. This is from last year's study that we ran up numbers and looked at those. So that's what I think I would do.
Okay, Dr. Bhatt, do you more or less follow what Dr. Warrior said, or you have anything else to add?
Yeah, in terms of clinical testing, there is a grading system which we follow, which is just about less than 50%, up to 50, and more than 50 when we do the translation in all the 3 positions. That is one. And second, I look at the displacement. So I take both the things together, and then I find it just how much of displacement. And then the only point I would like to make is always open it and fix it. I mean, there are a lot of people who try to think that it can be put percutaneously. No, it's not. It's an avulsion fracture. And there is a nerve sitting there, the dorsal sensitive branch of the ulnar nerve. So please be careful when you fix the ulnar style. Take a position, visualize the fragment, pin it back nicely into the spot. Even if it goes on fibrous union, it's fine. But then you need to at least get it back there to the raw area there nicely. That's the only technical point I would like to make.
Yeah, thanks, Anil. Dr. Padankar, your final comments on this? Anything would you would like to add to what Dr. Warrior or Dr. Bhatt has said?
I think I also don't know if it's 3 or 4 per year. Only when the reduction of the radius is very difficult, or you get that springy feel, and the radius goes back to its deformed position. That means that the ulnar styloid is causing mischief. And then you open the ulnar styloid first, fix it back, and then you do the radius. I don't do more than 3 to 4 per year out of all the radius which I do. So it's not a very common surgery, but you have to know which radius is not giving you a reduction. Even on table, after opening the radius, you feel the radius is not, your assistant is giving traction and your radius is just not falling back in place. That means that the ulnar styloid is a culprit.
Yeah, I think that's a wonderful point. Sometimes ulnar styloid fixation can actually make your dorsal and volar lunate fragment reduction much easier. Yeah, thanks a lot, gentlemen. Amit, there is a question for you.
Okay.
Would you explain what exactly is an humpback deformity in as less time as you can?
Yeah, in humpback deformity, there is collapse in case of, see, if we take an example of waist fracture, there is collapse of the waist fracture, and due to this, the proximal fragment of the scaphoid get extended because it is attached to the scaphoid with the help of scapholunate ligament, and distal pole of the scaphoid gets flexed because it is attached to the triquetrum with the lunotriquetral ligament. So
Amit, with your permission, can I run a 2-second animation to answer this question?
Yeah, please.
Yeah, I'll just do that. Just give me a moment. Yeah, this would explain what humpback deformity is. This is a scaphoid fracture, and when a scaphoid fracture collapses, it leads to certain amount of carpal collapse, where the lunate starts looking dorsum and takes the proximal fragment with it, and the distal fragment starts flexing, and the deformity that you now get in the scaphoid is called the humpback deformity. I hope these answer the questions for the person who asked this.
Yeah, nice animation.
Yeah. So now I will go on to the next talk now, which is by Dr. Prashant Kamble. Prashant Kamble is Associate Professor of Orthopedics in KEM Hospital, extensively trained, extensively traveled, is proficient in wrist arthroscopy, and he's going to tell us about perilunate dislocations in as simplified fashion as it can be. Prashant, we can see your first slide.
Yes, yes. Thank you, Dr. Pankaj, for introduction, and I thank Dr. Parag and ISS team for giving me this opportunity. So the topic today is how to simplify perilunate dislocation. Okay, this I'm going to very basic how to read the normal X-ray, what you are supposed to see, and then we'll see the Mayfield's progressive perilunate disruption. So to start with, these injuries are complex and usually as a result of severe trauma. And as literature suggests that their 25% are missed at initial presentation. This could be because of a polytrauma patient that needs urgent attention to other severely damaged part, and sometimes the treating surgeon is unaware of these perilunate dislocation and could lead to long-term functional disability and chronic pain. So this was one of the example where surgeon has fixed the scaphoid but completely failed to recognize there is a perilunate injury as well. So let's try and understand what is a perilunate dislocation. So as the name suggests, it is something around the lunate. And what is around the lunate? It is the other carpal bone. And these other carpal bones are attached to the lunate by means of their interosseous ligament or some extraosseous ligament. So in order to understand, let's go through some small normal carpal kinematics and small normal X-ray, what you are supposed to see. So I must thank Dr. Simon for sharing his 4DX motion on wrist range of motion. So as you can see this during radial deviation, the scaphoid undergo flexion, and on ulnar deviation, scaphoid extend. So just to keep this remember for this point of time, otherwise this video will be extremely helpful to understand other part of carpal instabilities as well. So just remember scaphoid undergo flexion during the radial deviation and extend that's during the ulnar deviation. So what normal X-ray when you see what you are supposed to look for? These are Glulas arc, scapholunate interval, and the shape of the lunate, which is normally like a rectangular shape. On lateral view, you are seeing the lunate, which is a half moon shape, and the sitting capitate. So you can correlate this capitate as like this. So this boy is a capitate, and this is sitting on the moon, and they are collinear with the radius. So this is how I remember. And let's now see the pathomechanics. This was described by the Mayfield in 1980s. He termed this as a progressive uh, interosseous ligament failure starting from the radial to ulnar side, and he described them into the 4 stages, and we'll see each stage in detail with some clinical cases, and as these are as a result of hyperdorsiflexion with ulnar deviation for an axial force, and as a result, as a complete disruption of the ligaments, the mid carpal joint, the distal root, is pushed dorsally relative to the lunate. So let's see in stage 1 what happens. So in stage 1, there is a disruption of scapholunate ligament because of the hyperdorsiflexion and ulnar deviation, and there is a rupture of scapholunate ligament. As you can see here, the scaphoid is flexed and lunate is extended, assuming a form of dorsal DC deformity. As we have seen in that 4DX motion, the scaphoid undergo flexion on radial deviation. So there is rupture of scapholunate ligament, and scaphoid is assumed to flex and lunate has migrated dorsally. So how some clinically sometimes these patient have tenderness at scapholunate, and where do you palpate is your listus tubercle. Keep your thumb at listus tubercle, and the tip of your thumb is exactly pointing at the scapholunate interval. So there are tests, Watson tests to check the integrity of scapholunate ligament. How do you do? Keep your thumb at the scaphoid tubercle and move your wrist from ulnar to radial deviation. As you can see that when you move your wrist to radial deviation, scaphoid try to flex, as we have seen that in 4DX motion video, and your thumb will push the scaphoid out of dorsal margin. This will be appreciated by patient as a pain or a click. So that assumes the Watson's test positive. How it looks like on X-ray? There is a widening of space between scaphoid and lunate. So there is a space increase, and this is can be a term as a Terry Thomas sign, named after the British comedian. But this is not always present. You may have to provoke this when you have high index of suspicion that scapholunate is ruptured, and you can ask for the dynamic clinch fist view, which the same X-ray, if you see now, there is widening of scapholunate interval. So why this happens? Because in rupture ligament, this capitate is trying to move and occupy the space between the scaphoid and lunate. So another sign is when scaphoid assumes flex position, it looks like a ring sign. So these are a few signs when you have a scapholunate rupture that you can see on the X-rays. Now coming to the stage 2, the deforming force continues and there is a rupture of ligament which are connecting the capitate and lunate. So the capitate lunate disruption occur, and capitate is forced dorsally with respect to the lunate. As you can see here, the capitate is moving dorsally. Remember the capitate, the boy is sitting in the lunate, half moon shaped lunate, now is moving out of his position, moving dorsally. Deforming force continues and there is a rupture of lunate and tricipiteral ligament. So whole of the ligament which are surrounding the lunate are ruptured now. An entire mid-carpal joint is shifting dorsally with respect to the lunate. How this looks on X-ray. Look at the green arrow. There is widening of space between lunate and tricipiterum. The lunate, which was a rectangular shape, has become now triangular in shape. On lateral X-ray, look, the lunate is pointing volarly, half moon shape, and this boy capitate is now moving dorsally and is getting articulating with the distal end of radius. This triangular lunate looks like a piece of pie. So this is termed as a piece of pie sign. Now stage 4, the most deforming force continues and all ligaments have ruptured, and lunate is now moving out of his lunate fossa because there are some ligament attached volarly to the lunate. That's a radiolunate ligament which will force lunate out of its fossa, and lunate will migrate into the distal part of forearm, and this stage capitate will come and sit with radius. This lunate looks like a spilled tea. So this is termed as a spilled teacup sign. So as we have seen, this is a progressive interosseous ligament failure from radial to lunate to lunotriquetral. So this is termed as a lesser arc injury, and as per the literature, this even if a treatment, this has a poorer prognosis compared to the greater arc injury. So what is greater arc injury? When the deforming force is started from your styloid, goes to the scaphoid, then capitate, and ends up into the tricipiterum and ulnar styloid. So this is called as a greater arc injury. So let's have some clinical cases. This patient, somebody treated, as you can see on the X-ray, there is a scaphoid fracture, there is a perilunate dislocation. So this is termed as a transscaphoid perilunate dislocation, and somebody put him in a cast, and this patient had tingling in median nerve distribution. So this patient need urgent decompression of carpal tunnel as well as the definitive fixation for the treatment. So what you do whenever you see this patient in emergency room, you reduce them in ER, and this should be followed by a definitive fixation. So just here, I'm just trying to show what, how do you reduce, actually, though it is just trying to mimic. So you give a longitudinal force, elbow flex, and keep your wrist under dorsiflexion, and then you push your lunate back to the lunate fossa, and then again you do a wrist flexion. So this is what I have done actually in emergency room. This is how it looks reduced, and this should be followed by a definitive fixation, which I'm not going to talk in detail. And this was his result at the end of 1 year. Some patient may present, as I said, these are high velocity injury, and this may present with the polytrauma. This patient had a lot of other issues like liver bleeding. There is a hemothorax going on, and this patient had open injury. Look at those carpal bone. Where are they going? They're maintaining their social distance. We don't want them to separate. We want, so put them back, fix them, and this was the result we saw early, and this was the late result. So some patient, as this was I've shown in first initial slide, this treating surgeon missed that there is a perilunate component as well, trans-scaphoid perilunate dislocation. So this was fixed only scaphoid and presented late. So this wrist has become stable, stiff, and painful, so which is needed some salvage treatment. So here the proximal row corpectomy where scaphoid, lunate, and tracheotomy is removed, and this was his result at the end of 3 months. So to conclude, in short, don't miss this uh, initial presentation. Whenever they present diagnose, remember those X-ray signs, what is like Terry-Thomas sign, and rest subsequent what I have shown in earlier slides. So if you recognize them early, treat them with open reduction and ligament repair. Acute stage is the key to success, and whenever they presented late, salvage procedure are required depending on the patient functional requirement and what is the presentation scenario. I thank you, organizer, for giving this opportunity.
Fantastic, Prashant. It's just not possible to do justice to peroneal dislocations in 8-10 minutes. That's
Right,
barely enough time just to spell it. But
right.
we'll wait for questions to come in because the live
Sure.
telecast is lagged by a few seconds. Meanwhile,
Sure.
I would ask Dr. Bipin Gangurde to speak to us about Kinbox disease. Dr. Bipin is a trained hand surgeon. He is a European diploma holder in hand surgery. He specializes in pediatric hand surgery. Has his private practice in Mumbai. He is attached to Wadia Hospital as well. Bipin, are you ready with your talk?
Yeah. Can you hear me?
Yes, we can hear you very clear.
Yeah. So my talk is about Kinbox disease, going away from all traumas. Now I'm talking about a disease of the carpus, that is a lunate bone. So it was introduced initially in 1843, which is a collapse of the lunate, and it was shown in cadaveric specimens. However, in 1910, Robert Kinbock described the changes associated with lunatomalacia. It is actually avascular necrosis of the lunate, and the treatment can be challenging and also controversial. So this is different etiological factors of Kinbock disease, like avascularity as described by Gelberman, repetitive microtrauma, ulnar variance has been come up, and Zopico has described lunate geometry. However, we should remember this, that there is not a single factor which can be isolated in case of this disease. So we have classified.
Dr. Bipin, can I interrupt? I think you're not sharing your screen because we cannot see your presentation. Can you share your screen, please?
I've shared my screen.
Because we can see you, but I cannot see your PowerPoint.
We are able to see Ashish.
Oh, I'm so sorry.
Yeah.
Okay. Some problem my end probably.
Yeah.
Okay. Now?
Now it's better. Yeah. I can see that now.
Yes. So in 1993, Lichman has come up with this excellent classification, which has given us a treatment line of management also. So he has said there is a stage 1 in which the X-ray is normal. However, bone scan and MRI is required for the diagnosis in stage 1. In stage 2, there are X-ray changes, which shows sclerosis of the lunate. The collapse of the lunate starts in stage 3 with normal carpal alignment in stage 3A. However, the altered carpal alignment and radio scaphoid angle greater than 60 degrees is seen in grade B. And stage 4 is lunate collapse with complete osteoarthritis of the wrist joint. Now, MRI shows a T1 weighted image shows a diffuse hypointensity of the lunate bone, and T2 weighted image shows hyperintensity and collapse of the lunate bone. However, in 2010, Littman came up with a new system, adding grade 0 and grade 3C. So what is grade 0? So this is intermittent ischemic episodes, which obviously cannot be seen on X-rays. So he said that contrast enhanced MRIs are needed to look at these intermittent ischemic episodes. Grade 3C, he described as a coronal split in the lunate with a collapse. So this is a clinical example of grade stage 1, which shows the normal X-ray. However, an MRI T1 weighted image shows that there is hypointensity of the lunate. Stage 2 shows sclerosis increase in the lunate, and the MRI also shows there is a bit of flattening of the lunate and hypointensity in T1 weighted image. Stage 3A, if you can see this line here, the carpal alignment is maintained. However, there is flattening of the lunate significantly. So this is the stage where there is a collapse of the lunate begins. In stage 3B, the carpal line is broken and the radioscaphoid angle is increased more than 60 degrees and it is static. This is grade 3C, which I have found out in my clinical experience, that there is significant flattening of the lunate. There is also involvement of the capitate. So if there is a capito-lunate involvement along with the radio-lunate involvement, this is stage 3, which has been described by Lichman in his 2010 paper. An MRI T2 weighted image shows this cyst in the capitate. Stage 4, I don't have a clinical picture of this because I haven't come across stage 4 lunate as of now. However, it is pancarpal arthritis and mid-carpal involvement with radiocarpal involvement. So there have been arthroscopic classification by Begg and Bain, which shows number of different classification for this Kinbox disease. So what is the aim of treatment? So aim of treatment in my scenario is to achieve painless wrist of movement to prevent carpal collapse, and grip strength should be comparable to the opposite side. In 2016, Littman has come up with this protocol, which he says that it should be divided into lunate protection surgeries, wrist reconstruction surgeries, and wrist salvage surgeries. So I have devised my own protocol. In fact, everyone has to devise their own protocols for Kinbox disease. So surgical treatment is only necessary for patients between 20 to 50 years of age who are in working age group. Less than 15 years, 16 to 20 years, and greater than 70 years can be managed non-operatively. So in stage 1, what I do is I conserve with a short-term cast for 3 months. And if they're symptomatic more than 3 months, then I reassess with MRI and X-ray and grade them and stage them accordingly to the Littman classification, which I have mentioned earlier. Stage 2, goal is to revascularize the lunate. How can it be done? It can be done with core decompression. It can be done with radial shortening or ulnar lengthening if there is variance, capitate shortening, and radial osteotomy. Personally, I follow this principle of core decompression and radial shortening. If there is a ulnar negative variance, I do radial shortening. If there is no variance, then I do core decompression as given in this 2017 paper. So this is the example of radial shortening in stage 2 Kinbox disease. So you don't have to shorten more than 4 mm as there might be DRUJ problems. This is an example of stage 3A. So what do you do in stage 3A? Your goal is to induce and allow revascularization. So induction of revascularization is necessary. How do you do it? You do it with vascularized bone graft, as shown by Stephen Moran in 2005. And other than this, there have been papers of core decompression, radial shortening, ulnar lengthening, capitate shortening, and radial osteotomy. However, I do what is called as vascularized bone graft. So Stephen Moran has described this technique of 4-5 extensor compartment artery. So what I call, this is a clinical picture in a case which I have done. So you have to see the 4th extensor compartment artery. the fifth extensor compartment artery, and they form they have a confluence here, and they form what is called as a trishul. So I see this trishul when I open the fourth and fifth compartment, and if you see this trishul, that means you are in the right area. Also, you can see there is PIN nerve is superficial PIN nerve is very close to this area. So necrotic lunate bone is the necrotic lunate bone is curated, and vascularized bone graft is harvested and inserted in the lunate. This is a 30-year-old woman in grade 3A Kinbox disease. Lunate synovectomy, necrotic bone removed, and at 2 years of follow-up, good range of movement. You can see significant radio-ulnar variance in this case with ulnar negative in a 25-year-old man in Kinbox disease grade 3A. So what I did in this case was 4-5 EBG and radial shortening. This patient had painless movement, but movement was restricted. Stage 3B and 3C I combine. Goal is to salvage the wrist. I do what is called as PRC, is proximal row carpectomy, which Prashant has ideally showed in his earlier presentation. And then PIN neurectomy is also done by me as an adjuvant procedure. STT fusion and scaphocapitate fusion also can be performed in these stages. This is a case in which proximal row carpectomy is performed. At 2 years follow-up, the patient has significantly good painless range of movement. That what is lifted in the Caesar is the PIN nerve. So proximal row carpectomy and PIN is done in this 55-year-old woman with a good range of movement. At stage 4, what is followed is wrist fusion or total wrist arthroplasty. I don't have experience with total wrist arthroplasty at all. So what is my protocol? Stage 1 is to conserve. Stage 2 is if there is no neutral variance, then core decompression, radial shortening if there is ulnar negative. Stage 3A, vascularized bone graft with or without radial shortening. Stage 3B, proximal row carpectomy with or without PIN neurectomy. And stage 4, I do wrist fusion. Thank you.
Thank you, Bipin. Very good presentation. I'm sure there are going to be a lot of questions, but we'll just wait for questions to you. Meanwhile, there are questions to earlier speakers, so I would request them to come online. Abhijit, are you around?
Yes, I am around.
Abhijit, are you around?
Yeah, I'm around. Can you hear me?
Yeah, Abhijit, there are a couple of questions for you. So how do you differentiate between lax DRUJ, physiological laxity, and TFCC injury? With that, I will read out a second question as well, so you can take them together. And then in a chronic DRUJ injury where you have a ballotment positive, in a patient who is a housewife or a low demand, I don't think a housewife is a low demand patient. I've discovered it in last 30 days.
I agree.
So we'll keep it to low demand patient. We'll remove the housewife out of equation. So you have a chronic DRUJ injury with ballotment positive in a low demand individual. What would be your management options?
Good question. So if I were to answer the first question, and which was how do you determine the degree of laxity in a constitutional? So you refer to the Baton's criteria, and then you examine all the joints, and then if they fit into the Baton's criteria, you would call it as a constitutional laxity. And pretty much like you have the, for shoulder, you have, say, for example, laxity, and you don't operate these patients. You put them on intensive rehabilitation. One has to understand that every joint, and also the DRUJ for that matter, has intrinsic as well as extrinsic stabilizers. So in such people, we work on strengthening the extrinsic stabilizers and by using a splint and NSAIDs and trying to relieve them of their problems. But despite your best efforts, they fail to respond to your treatment. I would rather do a tenodesis procedure or a capsulodesis procedure rather than going after the TFCC intra-articular. So I hope that answers the question. The second question is, in a low demand patient, I would first begin with a non-operative line of treatment, including splints. I would begin with
Abhijit, this is a chronic injury. This is a neglected injury.
Yes.
So yeah.
So Okay, this is a chronic neglected injury. Well, then one has to determine what exactly is the cause of the pain. One has to appreciate that the TFCC is just one reason why people will have instability and symptoms. It might be because of tear of the capsule, stretching of the capsule. It might be because of a ECU subsheet tear. It might be because of a snapping ECU. So you have to first go to the diagnosis and deal with it accordingly. If it is a TFCC or one or either of the radioulnar ligaments, I would do a tenodesis procedure such as the Adamberger procedure. If it is an ECU subsheet tear with instability of the ECU, I would do an ECU stabilization surgery. There are multiple tenodesis procedures. If it is a unidirectional instability, I would do something like the modified Nakamura procedure. So there are multiple or many ways to skin the cat, but you have to diagnose the root cause of instability and then go after it.
To summarize, so if you have an unstable joint, even in a low demand patient, if you have a good articular cartilage, you will do a reconstruction.
Correct.
Okay. There's a question.
Can I just very quickly put one point across?
Sure.
So the way I like to look at the distal radioulnar joint is whether patients are present to you only with pain with instability, and pain with arthrosis. If it is only pain in a stable DRUJ, my first line of treatment is non-operative. Sometimes they have a central perforation or synovitis, and that can be dealt with arthroscopically if they fail to respond to non-operative treatment. If it is instability in the absence of arthritis, you do a tenodesis procedure or a TFCC repair based upon the duration. If it is chronic, you do a tenodesis. If it is acute or subacute, you do a TFCC reinsertion or a repair. If there are arthritic changes, based upon the age, the demands, and the expectations of the patient, you do a salvage procedure.
Perfect. Thank you.
Thank you.
Anil, are you around? Yeah, Anil, hi. So there is a question, is DC and humpback deformity one and the same thing?
Definitely not. One might lead to the another one a lot of times, but then basically we are talking of scaphoid and lunate, two different things here. And the basic culprit there is the link. So when you have something towards the link, when I said like the proximal pole tiny fragment, which is towards the link, which is the scapholunate ligament, which is attached to the lunate, obviously, it can cause instability with a DC kind of a deformity. But humpback is not about that. Humpback is purely about scaphoid and what has happened to two fragments of the scaphoid. There could be on the volar side, there could be resorption of the bone or comminution leading to humpback. There could be instability leading to the humpback. So there could be so many causes why a humpback can happen. So it could be structural, it could be instability due to basically the ligament injuries. So both can cause this. But in terms of a DC, it is basically what we're talking is the entire scaphoid or a proximal pole attached to the scapholunate. One of these things are altering the instability or rather the stability patterns and causing the damage there. So they might be related in some way at one point of time, but it's not the same. Both are
so the humpback deformity refers to the scaphoid itself, and it can give rise to a radiological appearance of a DC. Whereas a DC itself is a dissociation between the lunate and the scaphoid, where the lunate starts going dorsally and the scaphoid starts going flexing. That's the true DC.
Yeah.
Okay.
Yeah.
Thanks, Anil. Prashant, are you online? Prashant?
Yes, I'm.
Yeah, Prashant, there are a couple of questions for you. In a lunate dislocation, volar lunate dislocation, or a perilunate dislocation, when you do open or a close reduction and you put pins, do you only put pins, or you have done a ligament repair and then you have put pins?
Yes, of course, you have to do a ligament repair in acute situation. Just putting up pins may not be suffice. But there are some literature they are showing arthroscopic assisted, just put up pins and K wires. And if subsequently, if you have a problem, then you go and do a secondary procedure. But given it,
Sorry. So between the scapholunate and the lunotriquetral, which of the ligaments you would rely on a K-wire more, and which of the ligament you would want to repair?
Yes, of course, scapholunate should be repaired, and a lunotracmetal, I would rely more on the K wires.
Okay, okay. And the other K wires are of course only K wires, the scaphocapitate and the
Yes,
radiolunate.
yes, yes, to stabilize the.
And can a PRC be done? Can a PRC be done for a chronic or a neglected lunate or a perilunate dislocation?
Yes, this is the option. You can have an option, but you need to have some prerequisite, which I mean to say, lunate fossa cartilage should be intact to do because capitate is going to articulate with your the original lunate fossa, and the patient should be explained there might be some amount of pain which will remain, and you may not have the maximum grip like which we get in a fusion procedure. But yes, the PRC is a good option for this patient, neglected patient.
Okay. As long as the capitate and the lunate fossa cartilage is good. Yeah.
Yes,
yeah.
yes.
Bipin, couple of questions for you. What do you mean by decoring, core decompression of the lunate? Is it the decompression of the lunate, or is it core decompression of the radius?
No, core decompression of the radius. It is an extra-articular procedure. However, there are procedures for decompressing the lunate also, in which synovectomy is done. So either of the procedures, but I personally do what is called in earlier stages is core decompression of the radius.
Core decompression of the radius. Okay.
I don't touch the lunate at all.
Okay. So when you say core decompression, you mean core decompression of the radius.
Yeah, yeah.
Okay. And if you have a stage 3 lunate, whichever A, B, C you can differentiate, do you do a scaphocapitate fusion, or it is only a temporary wire that you have put?
Scaphocapitate fusion. I don't have personal experience with scaphocapitate, but people do it. Scaphocapitate fusion, but I personally have no experience because these are small fusion areas. You really need to have the small burrs.
But sometimes would you put a K wire across just to keep the lunate decompressed?
Procedure.
Yes.
It can be used as an unloading procedure temporarily. I personally don't do it, but many of my colleagues who do a vascularized bone graft put a scaphocapitate wire to unload and then remove the wire.
Perfect. Okay, so it can be used as a temporary measure.
Yes.
Okay. Thank you, gentlemen. All those who spoke in this session, it was a wonderful session, very informative. Now we move on to the next session, which is on hand and wrist infection. Ashish, is Ashish around? Ashish, do you want to take over this session?
No, I think you take over because.
Fine. So yeah, I now invite Nilesh Sadbai to talk to us about hand infection. Nilesh is a very accomplished microsurgeon. He is the current secretary of the Indian Society for the Reconstructive Microsurgery. Are you the secretary of APSI also?
Oh, I'm the EC member of APSI.
Okay, he's a EC member of Association of Plastic Surgeons of India. Does phenomenal brachial plexus surgery and microvascular reconstructions. He's going to speak to us about acute infections in the hands.
Thanks, Pankaj, for the kind introduction. I'm talking on infections of the hand. This is quite an extensive topic, and hence we have split it in half. So I'm talking on the first half, and then Parag will take over. So I begin the talk. My screen is not moving. Yes. Yeah. So I make a mention of this gentleman, Dr. Alan Cannabell. He was a general surgeon from Chicago who treated hand infections in the pre-antibiotic area. And his extensive dissections and innovative injection studies have helped us base our knowledge and treatment protocols of hand infections to a great extent. Hand infections are quite common. They can result in severe disabilities such as stiffness, contractures, or also amputation at time. The antibiotics have helped us to a great extent in dramatically reducing the morbidity and associated with these infections. They, however, do not replace the need for surgical interventions. There are several factors which influence the outcome of a hand infection. These are the location of an infection or the infecting organism, the timing of treatment, adequacy of surgical drainage, efficacy of antibiotics, health status and immunocompetence of the patient. The etiology of the hand infections can be different. It can be due to an open injury caused by trauma, animal bites, human bites, drug abuse. It can be due to hematogenous infections or iatrogenic infections caused by pin tracks or surgical sites. So the typical pathophysiology of any infection is after the bacterial inoculation, there is acute inflammation, which results in an increase in the compartmental pressure, reduced vascularity and circulation of that, leading to tissue necrosis and abscess formation eventually. Alternatively, the bacteria also secrete some toxins which can lead to tissue necrosis and abscess formation. This is the bacteriology associated with hand infections, which we must be aware of because sometimes they have a really different kind of presentation, and that leads to inadequate or inappropriate treatment. The Staph aureus or the Streptococcus are the most common organisms. However, sometimes there can be a mixed picture or a mixed or a multi-organisms causing infection. These are the mycobacteria, which are very common in this part of the world, and these infections are noted on and off in some patients who are not responding to the standard line of treatment. As it takes two to quarrel, so it takes two to make a disease. So along with the microbe, it is also the host which is important to determine how the infection takes its course. There are several host factors which determine how the infection will progress. The age of the patient, diabetes mellitus, malnutrition, alcoholism, autoimmune diseases, chronic corticosteroid use, renal failure, hepatitis, and HIV. All these have a severe impact on the progress and outcome of infections. Certain occupations are more prone to specific kind of infections, so the history of the patient can give us an hint of what the infection could be, such as the herpetic whitlow, which occurs in medical and dental professionals. Gardeners more often pick up sporotrichosis. Chronic paronychia is common in people exposed to water and detergents. Marine workers and animal farmers are exposed to typical organisms. The patient evaluation is important, like in any other situation. The local examination will indicate pain, tenderness, increased temperature, erythema, swelling, painful movements, fluctuation, and pus discharge. Systemic signs such as fever, myalgia, chills, lymphangitis, and lymphadenopathy should be noted. Investigations depends upon what the condition is. In relatively early onset investigations are not really essential, but in chronic infections, yes, they do matter. The WBC count can be raised. The ESR or CRP are non-specific indicators, but they can give an idea of what is happening. Diagnosis of diabetes and its control is extremely essential. Wound swab may indicate what is the organism causing the infection. Tissue biopsy is also an indicator, and radiographs can give us an idea of presence of a foreign body or gas within soft tissues, fracture, arthritis, and osteomyelitis. The treatment principles in general, most of the cases require surgical drainage. A large incision is usually used. The incision should be extendable. It should minimize the exposure of blood vessels, nerves, and tendons, so as to avoid future healing problems. And we should avoid longitudinal incisions across the flexion creases. The wounds are most often left open. The large wounds may be subjected to negative pressure dressings. Multiple debridements are usually essential to get rid of the infections completely. Loose dressings are often used, and there is no rush to close the wounds primarily. And many times the wounds are left for healing by secondary intention. The postoperative care involves frequent change of dressings, immobilization by splint, early mobilization to prevent stiffness. Multiple debridements are often essential in complicated infections. Amputation is sometimes a better option for a stiff, painful, or a non-functional digit. Empirical antibiotic therapy is started in most of the cases, and then it is shifted over to a specific therapy depending upon the culture. So the common hand infections are usually acute paronychia, chronic paronychia, pulse abscess of the phelon, pyogenic flexor tenosynovitis, deep palmar space infections, dorsal infections, infections of the wrist joint, and septic arthritis and osteomyelitis. These are some other causes which are not very uncommon: animal bites, human bites, prosthetic and implant infections, shooter's abscess, which are typically seen in parental drug abuse, septic thrombophlebitis, herpetic whitlow. Diabetic hand infections are gradually increasing, just as the diabetic foot is common. Necrotizing fasciitis and gas gangrene are special situations. These are some mimickers of infection which we must know so as to not misdiagnose these cases: gout, pseudogout, calcific tendinitis, pyogenic granuloma, pyoderma gangrenosum, retained foreign bodies, and metastatic and primary tumors. Acute paronychia. So this is the most common infection of the fingertip. It involves the soft tissue fold around the nail. It is generally treated by a primary care physician or a general surgeon or a general orthopedic surgeon, and hence it is very important to know the anatomy of the finger and the extent to which the infection can spread to treat it adequately and appropriately. Many a times patients are inadequately treated, and hence they'll end up with refractory or infections and complications. So this is the anatomy of the nail complex, the paronychial folds and the eponychium, and the pulp tissue of the finger. So knowing this anatomy helps us in knowing the typical tracks which these infections usually take. The infections typically occur by bacterial inoculation of the paronychial tissue uh, in a hangnail or a manicure instrument, causing damage or nail biting. The clinical symptoms are, as discussed already. The preoperative evaluations also is not required in many or most of the cases, but sometimes in resistant cases, yes, we do need them. These are the spectrum of cases with an early onset paronychia. This is a paronychia with an abscess tracking under the nail. This is a abscess along the fold which is started to drain itself. The treatment options in the early stage, antibiotics and rest and elevation do help. Superficial abscesses, the elevation of the cuticle helps in drainage. The incision and drainage is sometimes essential for adequate and complete drainage of the abscess. Antibiotics are given for a period of 5 to 7 days. The deeper abscesses definitely need drainage in all cases. The incision is usually directed away from the nail bed. The nail plate can be partly or completely removed so as to drain the abscess completely. We must always check for volar extensions of these abscesses because many a times they track along the pulse space or along the distal phalanx, and these can be missed. The bony involvement also needs to be assessed clinically as well as on X-rays. This is another method of drainage of the abscess in situations where it is tracking under the nail plate, where the eponychial fold is cut on both the sides and reflected, and the nail plate is then cut to expose the nail bed. Pitfalls: it may be misdiagnosed as an herpetic whitlow, in which case the treatment option is totally opposite. It is treated conservatively. In fact, surgical treatment of an herpetic whitlow may lead to systemic viral infection. Hence, it is important to know the difference in the two situations. Failure to recognize underlying osteomyelitis and atypical infections. Postoperative management is, as discussed, 5 to 7 days of antibiotics, frequent change of dressings. It may still land up with nail deformities if inadequately treated. A persistent or a recurrent infection can cause um, uh, problems again, and the scars may lead to hypersensitivity. Chronic paronychia is a different condition altogether. It is a chronically indurated and rounded eponychium, which results from repeated episodes of inflammation and drainage. There's thickening and grooving of the nail plate. It typically occurs in middle-aged women, the females being more common. Frequent water immersion and exposure to detergent and alkaline solutions. Housewives, bartenders, dishwashers are more prone. Diabetics typically are more prone to these infections.
Dr. Nilesh, we will need to keep to time, please.
Yes. So the infection begins along the nail folds, and then the repeated cycles of infections leads to fibrosis and thickening, leading to chronic paronychia. The treatment could be topical corticosteroids, topical antibiotics, or antifungals, and reduce exposure to these environments. Eponychial marsupialization is usually required to be done in such cases where a crescentic shape of eponychium is excised and the wound is left open to heal on its own. The nail removal simultaneously can be done if it is deformed. That also is said to improve the healing rates. Phelon is a pulse space abscess. The pulse space has a typical anatomy, which is described as a closed sac connective tissue network with multiple vertical trabeculations, and which are packed with fat globules. This is another picture showing the same. So it is an subcutaneous abscess of the distal pulp involving the septal compartments. It causes a compartment syndrome, with Staph aureus being the most common organism. The injuries could be penetrating injuries of finger stick phelons, which occurs in diabetics. The clinical symptoms is throbbing pain because of the high sensory nerve endings at the fingertip, a tense swelling, but typically which does not cross the DIP flexion crease. It can lead spread to the bone or to the skin, or can lead to other complications. And the aim is to preserve the finger pulp sensations, the tactile sensibility, and the stable pad for pinch. These are the different incisions for drainage. The lateral incision is the preferred one. It is slightly dorsal to the neurovascular pedicle to prevent injuries to the neurovascular pedicles. All the septal compartments are released to drain the pus. The distal phalanx is assessed for any changes. The complications again are typically pulp atrophy, pulp instability, and amputation sometimes is needed for severe bone infection leading to refractory or recurrent infections. We'll just run into two cases.
Dr. Nilesh, can we come back to this if time permits, so that because we will have to move on. Dr. G. Balkrishnan, Dr. Ravi Mahajan are online waiting for us. So we will come back to clinical examples if time permits. Is that okay with you?
Yeah, absolutely.
Yeah, perfect. Thank you, Dr. Nilesh. Now I invite Parag, Dr. Parag Lad, who is the convener of the CME, who's taken tremendous effort to talk to us about involvement of the wrist and the finger flexors in infective tenosynovitis.
Can you see my screen, Dr. Pankaj?
Yes, we can. Yeah, we can.
Okay.
You can just run the presentation.
Yeah. So I'm very sure I would like to simplify this topic by understanding there are two basic parameters for tenosynovitis of the hand and wrist. One, we try to find out whether the cause is infective or the cause is inflammatory. And infective, the commonest causes are bacterial. I have not surprised in my practice that Cox is also one of the very common cause as a infective tenosynovitis. Let us now understand each and let us now just a minute. Yeah, when we consider a lab diagnosis for such cases, the infective causes are, we have to find out whether the ESR or CRP is high, and many times the inflammatory tenosynovitis are referred to us by a rheumatologist or a physician, and we need to consider this battery of tests. When should we consider a ultrasound or a MRI in when we see such cases? When try to find out clinically whether the pathology is inside the joint or outside the joint. We should consider ultrasonography when we are considering a localized disease. If the relatively non-tender area, sometimes skin condition or a ulcer or a burst abscess and too much tenderness along the digit, usually we should consider a scan. And if you are not suspecting any skip lesion or the disease is more localized, we should consider ultrasonography. I am going to discuss 4 to 5 cases. Like this case, the patient had a post-traumatic injury at the thumb tip, probably while cutting the vegetable. And if we see, there are signs of phelon also. So there is a nail bed infection. And this redness along the thinner aspect suggestive of flexor pollicis longus, as well as the dorsal aspect is suggestive of extensor pollicis longus tenosynovitis. These patients usually need a thorough debridement, and once you debride them and take a culture, and then these patients usually heal well in by primary intention. And these cases have to be done under digital under the local regional anesthesia and tourniquet. Usually wound healing is never an issue, and they usually have excellent result. Apart from infection, now let us consider one more case where this patient had a diffuse lobular swelling along the full length of middle finger. Functionally, she was better, but there was localized tenderness and there was no other history. So in this case, we had done a MRI because the swelling was right from the FDP insertion to the palm. And if we see a MRI, the black shadow is a suggestive of tendon and the white shadow is suggestive of extensive, I mean hyperintense lesion. So when we did an exploration, we could see a extensive flexor tenosynovectomy. Such usually lesions, we do a culture as well as we a biopsy. This patient was diagnosed to have sarcoidosis, and I mean, the rheumatologist had started a AKT for that treatment. Let us take one more example of a 58-year-old who had a liver cirrhosis due to primary portal hypertension and no history of trauma, and he had significant tenderness along the dorsal aspect of the wrist. These were the blood parameters. When we consider his MRI, there was intracapsular hyperintense lesion in the wrist joint. There was some white shadows on the dorsum of the wrist, and then we decided a exploration of the wrist from the dorsal. I would like to show you how a pathological tenosynovium sounds when we cut. Usually a normal tenosynovium will not sound like this. And apart from that, we had to consider an intracapsular synovectomy also in this lesion. And as the patient was 58-year-old, already started developing CRPS symptom, we had to consider a neurectomy of this patient, because that was the reason to control the pain. And after that, the CRPS was certainly improved. If you see the same patient, uh, if you see this patient at follow-up, and all wounds were healed by primary intention, and histopathological diagnosis was non-specific tenosynovitis, and he definitely have had a reasonable range of movement. Sometimes we see a iatrogenic infection. I have seen that we may consider de Quervain's disease or a trigger finger release is a small surgery. If the proper aseptic precautions are not followed during these surgeries, they can have a significant infection. And here I am doing a first extensor compartment release completely, and there was infected tenosynovium. The culture came up Staphylococcus aureus, and usually if your debridement is proper, they all heal by primary intention. In this video, I am doing neurolysis of the superficial radial nerve, and these patients usually they heal by primary intention with good range of movement. So her CRPS recovered the moment we considered the neurolysis of the superficial nerve and we controlled the infection. Now I would like to take one more case. Like, this was the case for a post mosquito bite injury. Whenever we are discussing tenosynovitis, we must discuss Canavel signs. What are the four Canavel signs? One is diffuse uniform swollen finger. There is a pain along the full length of the flexor tendon. Many times the passive extension of that particular finger is painful, and then you see a redness. So for that patient, we had to, now this video will suggest that we have taken a small incision at the distal sheath, and we have taken an incision on the proximal sheath as well. And now I am going to drain the pus from proximal to distal. There was not significant pus, but then we opened this finger very early in time, and that's why we could manage to get a good result. But now here, such cases, usually I pass a infant feeding tube along the sheath, and this is helpful for putting a diluted betadine lotion to control infection for 24 hours. And this usually heal by well in secondary intention. This is the case. Young lady had come with a no history of trauma, but abscess formation around the dorsum of the wrist. And if you see the MRI picture, the X-ray was normal, but the MRI picture showed a significant collection, and that was a proper pus formation. And it turned out to be tuberculous abscess, and this patient had a reasonably good functional outcome. Though she had a restricted flexion, this follow-up is at least a 1.5 month follow. Now she is much better with anti-tuberculous treatment. So many times sometimes we see a carpal tunnel syndrome very commonly, but please try to examine such patient whether they have a reduced grip strength. Whenever we see a reduced grip strength in a patients of carpal tunnel, usually we suspect a hypertrophied flexor tenosynovium. So after a nerve decompression, we must consider a proper tenosynovectomy of this particular in cases of carpal tunnel. So that it can be done by mini open carpal tunnel surgery, but usually when the significant grip strength is less, I try to consider a complete tenosynovectomy for this. And to my surprise, when I sent this for biopsy, it turned out to be rheumatoid etiology. If pre-op diagnosis, it was not there. The take-home message is tenosynovitis of the hand and wrist will always you will find the etiology. Try to find out. Surgery is for not only synovial biopsy, but sometimes the total synovectomy definitely relieves the pain and improves the function. And when to consider a USG and MRI, that I have diagnosed. When we are considering a skip lesion, then please consider MRI. And surgery has to be done under regional anesthesia and tourniquet. This cannot be done under local anesthesia but yes, Wallant can be described, but I would prefer a regional anesthesia. Thank you very much.
Thanks, Parag. We don't have questions for this session yet. There are questions for other sessions, but I think we will take it a little later. Now I invite Nilesh again to talk to us about principles of tendon repair. Nilesh, sorry, I had to cut you short in the last talk, but I was under considerable pressure to ensure that we cover up some time.
Yes, we'll cover up for the last time in the previous session.
Perfect. Over to you, Nilesh.
Thank you. So I'm now talking on tendon repair. I'm talking on some basic concepts before the other speakers talk on the acute tendon repairs, the secondary tendon repairs, and the extensor repairs. The scope of this talks involves the anatomy of the tendons, the tendon nutrition, the tendon healing, and the practical tips and considerations for tendon repair. I again make a mention of Frank Netter, who is called as a Michelangelo of medicine, for his wonderful drawings and explanation of anatomy of the tendons. We'll rush through the extensor anatomy. These are the extensor muscles arising from the lateral epicondyle on the dorsum of the forearm, running across the wrist into the six named compartment, which has different tendons. These are the superficial layer of the extensors and the deep layer of the extensors, and you can see the tendons crossing over the wrist to their respective areas of insertion. This is again the anatomy explained beautifully at the dorsum of the wrist and the six extensor compartments containing the respective extensor tendons. This is a cut section of the same showing all the tendons on the dorsum of the wrist. These are extremely important in cases of complex injuries where you need to identify and repair all the tendons, or in cases of tendon transfers or secondary tendon surgeries. I make a mention of these junctura tendinae, which are connected to the ring finger to connected to the middle and the little finger, and there is a flimsy junctura also between the middle and the index finger. These can retain the finger extension when there is a proximal cut injury of the extensors. So these need to be retained or known carefully. The index finger and the little finger have a separate extensor of their own, which permits them to have independent extension as compared to the middle and the ring finger. So the this is the anatomy on the dorsum of the dorsum of the digit, with the extensor tendon inserting onto the base, forming a central slip and dividing into the two lateral slips, inserting onto the base of the middle phalanx. The lateral bands connecting to the lateral slips, forming the conjoint lateral bands, and then going on to be inserted into the base of the distal phalanx. The another mention is of the triangular ligaments, which hold the lateral bands together, and of the retinacular ligaments, the transverse and the oblique retinacular ligaments, which are extremely important for PIP and DIP joint extension function. So these are the zones of the extensor tendons, which we must know. The odd numbers are on the joints. Initially mentioned were only 8 zones by Kleinert and Burden, and Doyle added the 9th zone, which is the muscle area in the proximal and the mid forearm. The flexor tendon anatomy. The flexor tendons, the origin of the FBS of the wrist extensors, the FCR, FCU, and the palmaris longus, and then the FDS and the FDP along with the FPL. These are the wrist arrangement of the flexor tendons at the wrist in 2 layers, the FDS and the FDP. This is the cross section showing the arrangement of the FDS and the FDP at the wrist. This is a simple test to remember that. So the digits have a fibroosseous system in the zone 1 and the zone 2, in which through which the tendons pass and are extremely important for the gliding and the nutrition of the tendons. This is again a picture demonstrating the fibroosseous system and the pulley system of the fingers. The pulleys are of two types: the annular pulleys, the A1 to A5, A1, A3, and A5 on the PIP, on the MCP, PIP, and the DIP joints. The C1, C2, C3, and the C4 pulleys in intervening areas. The cruciate pulleys are thin and flexible. They collapse like an accordion, where the annular pulleys are stronger and they hold the bone, hold the tendons to the bone. The pulleys are in three layers. The innermost layer secretes and facilitates the gliding. The middle layer is rich in collagen and it resists the palmar translocation of tendons. The vascularity of the tendons is quite well defined. It has multiple sources: the ventral system, the osseous bony insertions, the reflected vessels from the tendon sheath, and the longitudinal vessels in the palm. The synovial diffusion also is an important component, and the parietal peritoneum, which allows for the nutrient delivery and waste removal. This is a cross section showing the vascularity entering the tendon through the dorsal aspect, which shows that the vascularity is more on the dorsal side as compared to the volar side. So this also has an implication in tendon repair, so such that the sutures are more placed in the avascular volar half of the tendon. These are the zones of the flexor tendons. They are divided into 5 zones. Zone 2 is the fibroosseous system, and zone 1 is distal to it. Zone 4 is under the carpal tunnel, and zone 5 proximal to it. This is the structure of the tendon, which is much like a nerve. From the primary fiber, the secondary bundle, covered by the endotenon, and then the major tendon bundle. The goals of the tendon repair are to allow for early rehabilitation, to allow for a normal range of movement, allow for primary healing at the tendon site, prevent adhesions, and to stimulate restoration of the gliding surface of the tendon. The main considerations technically are the core suture size and configuration, epitendinous sutures, the impact of gap formation, and the role of rehabilitation. The core suture, it provides the main resistance to the repair site gapping, and the core suture strength in turn depends upon the type of the suture material, caliber of the sutures, number of suture strands crossing the repair site. The suture site, yes, the thicker the suture, the better it is, but thicker sutures creates a problem in putting multiple strands at the site of the repair. Hence, the suture has to be selected appropriately as per the tendon size and the number of strands that need to cross the repair site. So there are different configurations described. The older two-strand repairs have been given up. These days, most of the repairs are done by multi-strand repairs. What the recommendation is that there should be at least a 4-strand repair. 6 and 8-strand repairs are even more preferable. These are the different configurations described. The multi-strand repairs involve more tendon suture integration, and hence they provide greater tensile strength at time 0 and also 6 weeks post-operatively. This study demonstrates that the 4-strand repair has much lesser strength as compared to the 8-strand repair, even after 6 weeks of the tendon repair. A locking grasp is said to be stronger as compared to a grasping loop. The position of the suture knot either within the tendon or away from the repair site has not been shown to have any significant impact. Epitendinous sutures were initially done to smoothen the repair site, but then later it was found that they augment the repair site strength at the time of the repair and also later. They also facilitate the tendon orientation and makes placement and tensioning of the core sutures easier. Gap formation has a negative impact on tendon healing. It leads to poor tendon healing and poor accrual of the strength. Early gaps can lead to a rupture of the tendon later. The gaps, if they are less than 3 millimeters, are said to acquire more or provide more strength to the tendon even 6 weeks after the repair. Tendon healing was initially it was thought that tendons heal by the adhesions, But then later Lundberg had described that primary tendon healing does happen, and this healing process has been described clearly as an early inflammatory stage, intermediate active repair, and late remodeling stage. The biology of tendon healing is important because the suture provides the strength only at the time of repair and for a few months later, but later on it is the intrinsic healing or the tendon repair response that determines how strong the repair will be. And these are the proteins and involved in the tendon repair and healing. Rehabilitation, there has been difference of opinion on this in terms of the passive protocols followed earlier and now replaced by the early active regimes. But now many of the units are shifting back to an controlled passive protocol, because it was shown that a movement of just 1.6 millimeter or more of tendon is sufficient to prevent adhesion formation. The role of fibrin glue for tendon repairs has also been studied, but there's no conclusive evidence as yet. The role of vitamin C also has been explored because it tends to reduce the fibrosis and it tends to reduce the adhesions. The extensor tendon repair is slightly different from the flexor tendon repairs because of the variable thickness of the extensors. The extensor tendons are thicker in the forearm and the wrist, and then they tend to get flatter and wider and thinner. At the hand and the finger level, the tendon thickness is as less as 1.75 millimeters and 0.65 millimeters. Hence, the suture configurations are different. These are the different suture configurations. At the distal level, naturally, a core suture may not be possible. As we go proximally from zone 3 to zone 4, a core suture followed by a running epitendinous suture is used.
Dr. Nilesh, I believe Dr. Nehete will cover extensor tendons in details. Yeah, thank you.
So we need to have knowledge of the tendon anatomy, tendon nutrition, biomechanics, and most importantly, a traumatic surgical technique and aggressive rehabilitation, and also a motivated surgeon, patient, and a therapist. Thank you.
Thank you, Dr. Nilesh. And I think we proceed to our next talk of the session, which is acute flexor tendon injury by Dr. G. Balakrishnan.
Yeah, Dr. Parag, are you ready with sir's talk, or do we have time for questions?
No. I am ready, but sir is himself presenting from the from his screen, so you can take a question.
Yes. So till sir comes online, Abhijit, are you online? Abhijit, can you hear me? Yeah, Abhijit, there was a question. How do you distinguish DRUJ pathology from ECU pathology?
I'm sorry, can you repeat?
How would you distinguish pain from DRUJ?
Yes.
From pain coming from an ECU pathology.
Okay. So, people will have ECU tendinitis or subluxation. As you gently pronate supinate, the ECU will subluxate. There may be an instability of the DRUJ because the ECU subsheath contributes towards the stability of the DRUJ. So what is essentially seen is a subluxation of the ECU. There may be tenosynovitis without subluxation. And then when you get an MRI done in the axial sections, you will see tenosynovitis in the groove, or you may see the ECU to be subluxed. And then this has to be differentiated from other causes of DRUJ pain and instability.
Pankaj, can you ask Dr. GB sir to share his screen?
Yeah, I will. One moment. Sir, can you hear me?
Yeah.
Yes. Good evening, sir. Sir, you need to start sharing your screen. There is a button, a green button at the bottom of your screen. You just need to say share screen and then run your presentation.
Sir, can I do it for you?
Please play.
Sorry?
Parag, please play the video.
Oh, okay, I will. Okay, share the screen. Sir, you need to speak.
Yeah.
Yeah, okay. Yes, sir.
You want me to speak or you are?
Yes, yes. No, sir. You have to speak this.
Okay.
Yeah.
Let them complete.
Yes, sir. I will move the slide ahead. Sir, we cannot hear your voice.
Yeah, I'm able to hear you.
You need to speak.
Good evening.
Sir. Yeah.
Yeah, I'll start.
Yes, sir.
Hey, where? Yeah.
Sir, I am controlling your screen.
Yeah. Please do.
Just.
Okay.
Yes. Yes, sir.
Put up the first slide, please. Yeah, I'll speak.
Yes,
Put
sir.
up the first slide.
Okay, fine. This is the first slide, sir.
No, the previous one is there.
Yeah.
Yeah. Thank you.
Yes, sir.
Parag, thank you.
Thank you, sir.
Okay. Thanks, Dr. Parag, and I should appreciate you for your efforts to conduct. Right. Anyway, thanks to all the people and good evening to you. I'm going to talk about acute flexor tendon injuries. Yeah?
Yes.
Now, are you able to hear my voice?
Yes, sir. Very well.
Yeah. So Nilesh has already talked about the anatomy and the healing. And now I start with flexor tendon healing. Okay. No, 1 minute. Go to the previous slide. So I have not completed that. Oh dear. Go to the previous slide. No. This is the slide. Yeah. Flexor tendon healing happens both. Right. Now the
record
already going on. Just leave it there. Yeah. Go to the previous.
Sir, we cannot hear you.
My dear, yeah. Parag, my slide is already on with the talk. Parag, my slide is already recorded. You just simply play. Okay?
Parag, can you hear me?
Parag,
माझा आवाज
can you hear me?
Parag,
Pankaj.
Yeah, I'm calling him.
Yeah, I think he has done a voice layer.
No, that we know. Just a moment.
Hello.
Give me a moment.
Hello.
Parag. Parag, you are not able to hear us. You are not responding to what we are talking.
So how do I do that? Just a minute.
Parag, are you able to hear me?
We are able to hear now.
Yeah, we are able to hear you, Neeraj.
Parag, are you able to hear us? If you're not, then remove your headphone and see.
Is your headphone out of battery, Parag?
Hello.
Parag, can you hear me?
Yeah.
Remove the pin. Yeah.
Yes, sir.
Move the PowerPoint.
Yes. I am doing that.
Now, I think your headphone is out of battery.
Oh, I didn't know.
Coming to the blood supply, the vessel.
Mute.
The central area. So the placement of sutures.
Parag.
Don't make it mute.
Parag, can you hear me?
I don't think he can hear you.
So don't run the slides now.
Hello.
Parag, you are not able to hear us, yaar, Parag.
So what? कसं करणार? आता येतंय का ऐकू?
Listen, I understand what the problem is, Neeraj here. Let me get this sorted out.
What is
Parag,
happening? Even
Parag,
I
listen.
have lost the this thing.
त्याची head-
म्हणजे the present GB sir is talking or not?
I'm
No,
talking.
he's not talking.
Acha, he's not talking and the presentation is only...
No. Please, Parag, listen to me first.
Parag, you cannot mute your speakers. That is what you're doing. You're muting your speakers.
Parag,
you're muting your speakers. That is a problem. Can you increase the volume? He's muted.
Neeraj, can you help me?
Yeah.
Parag, yeah. Pankaj,
Yes, sir.
Are you able to hear me?
I can hear you very well, sir.
Now go to my slides, run the slide, I'll speak.
I cannot run your slides, sir. Parag has to run your slides.
Hello.
Yeah, Parag, can you hear me?
स्पीकर वॉल्यूम 0 कर रहा है इसलिए तेरे को सुनाई नहीं दे रहा है. स्पीकर वॉल्यूम फुल पे रखना पड़ेगा तेरे को अपना.
वो किया है मैंने, लेकिन वो जीबी सर भी बात कर रहे हैं, ऐसा हो रहा है.
Now I can hear you,
तेरे को
sir.
डबल साउंड सुनाएगा, बाकी लोगों को सिंगल ही सुनाई देगा.
Okay, so now okay.
ठीक है.
अभी बराबर है.
Parag, we can hear you now. Can you hear us?
Yes, I can.
Yeah, so keep your phone aside now, please. Yeah, thank you. Now you run the slides for Dr. GB.
Zone 1 area
Yes.
and do a primary repair.
They are on automatic mode to move forward.
And the wall of plate.
Yes.
If the distal curtain is less than 1 centimeter, we advocate advancement of the tendon and suture it to the base of the terminal phalanx.
Parag, please.
Parag, your slide is not on. Your screen sharing is off. Your screen sharing is
My
off.
screen is off, my dear.
Just a minute, sir. Just a minute.
So let's do one thing. GB sir, we'll just put you on hold for 10 minutes, sir. Is it okay, sir? We'll figure this out.
Let's do Dr. Nate's talk.
Why? Parag has to run my slides. Yes.
Yeah, we'll figure it out in couple of minutes. We'll put you on hold for 10 minutes and we move on to the next stop.
Yeah.
Sorry, sir. Rajendra, can you go ahead with your talk, please?
Yeah, I'm ready.
Yeah.
Can I share the screen?
Yes, please.
Did you get it?
Not yet.
Now?
Rajendra, you need to start sharing your screen.
Yeah, okay, 1 sec.
Dr. Rajendra Nehte is a prolific plastic surgeon, a gifted microsurgeon and a plastic surgeon. He's practicing in Nashik, has a fantastic setup, and he's going to talk to us about dilemma in treating extensor tendon injuries in various levels. Rajendra.
Yeah. First of all, let me congratulate Parag and the whole team for organizing this midterm CME like this. I think there are a good number of viewers more than the physical attendance. But he's not done justice to me because this topic requires more than 8 minutes. But then I will restrict myself to only zone 1 to 5 because that is where the problem lies in extensor tendon. If you take zone 6 to 9, the results are poor. The results are good, but in zone 1 to 5, generally, in fact, zone 1 to 4, generally the results are poor. And for the obvious reasons which Nilesh already discussed, when you talk about the expected outcome and results of extensor tendon injury and repair, the loss of digital flexion may be greater than the residual loss of extension. So there are Miller's criteria. The excellent result is 0 extension lag and 0 loss of flexion. In good, there is 10 degrees of less than 10 degrees of extension lag. So a lot depends on excellent repair of extensor tendon. It is essential because resultant loss of flexion is more disabling for the patient than the extensor tendon itself. So when this patient presents, it can be an acute injury, either a closed or open laceration. But many times I observe almost 50% of my injuries in this 1 to 5 zone are delayed presentations. And many times these are neglected close injuries or these injuries are missed by the primary physician, even in the open wound. They just suture the skin and the underlying tendon remains unrepaired. And sometimes what we get is failed previous surgical repairs. So if you consider the peculiarity of the extensor tendon, there is a flat tendon which is subcutaneous. So core suture is not possible in this flat tendon because it will cut through. And because resultant is the repairs are weak. So zone 1 to 5 repairs are not amenable to early motion protocols as we do it in flexor tendons because the repairs are not really strong. So when we talk about zone 1 injury, I think mallet finger has already been covered by Shailesh, but still I will cover it. It requires a basket weave suture. You cannot take a core suture in this region, but you can use a modified suture like this. This was a 50-year-old lady with mixer injury on 5th March, presented on 22nd March with heel laceration and mallet deformity with no evidence of fracture. This was in 2012. So this surgery was done and 2 mattress sutures. Though I say that we use the basket weave suture, sometimes if I get a good amount of tendon, I take a different type of sutures. So I took a 2 mattress sutures with 5-ethylone, and then I use axial K-wire for 4 weeks to support the DIP into either neutral or in hyperextension. And after removal of the K-wire for next 6 weeks, I use a splint. I don't use the ready-made splints. I will explain about it in later. And this is 6-year post-op. Can you see the video?
Yes.
Yeah, okay. This is the 6-year post-op. And you can see an excellent function of the DIP joint with good flexion and extension. So can they be managed conservatively? Yes, some of them can be managed, especially in the close injuries. In zone 1, Doyle's type 1, which is a close injury, and type 4B, which is a fracture more than around 40% or 50% of the distal phalanx base articular area, then it cannot be. But type B, where there is a smaller fragment, can be managed conservatively. And in zone 2 also, some of the close injuries can be managed conservatively. This was 24-year-old male with cricket ball injury on 19 March 2013, a ring finger mallet injury. There was no evidence of fracture on X-ray. So this is what is the splint which I prefer. This is the thermoplastic splint prepared by my therapist. There are readily available splint like Stack splint or Fox splint, but Stack splint I feel doesn't give a good hyperextension of the DIP joint. Whereas the Fox splint, I always landed up with the skin problems or the pressure points. So I stopped using it, and we make a customized mallet splint of a thermoplastic material, and we use the Velcro straps and maintain it properly. And I'm very happy with this because we don't have any skin problems with this. This is the flexion and extension at 5 years follow-up, and you can see a video at 5 years. There is no extension lag, and flexion deficit of DIP is less than 10 degrees. In zone 1, in type 4C, whenever there is a fracture, which is more than 50% of the articular surface area, you can see a mallet finger. This was injury was on 23rd Feb 2013, and we operated it on 2nd March after 10 days. And you can see a fracture attached to a tendon base. So I fixed it with intraosseous wire and axial K wire. Sorry, I didn't take the photograph of the intraosseous wire. But then when we removed the splint after 4 weeks, when I removed the axial K wire, this again went into a mallet finger leading to a swan neck. So when we took an X-ray on 11 March, you can see the fracture fragment is not in position. So what is to be done? So many times I manage these patients again conservatively. So in the same position, I splinted it for 6 weeks, gave a good supervised splintage. And this was June 2013. He had an excellent extension of the finger and a flexion also started. So if I took an X-ray in June, you can see the well space in the mallet with good space in the joint, as well the restoration of the articular surface. And this is a 5 years post-op. You can see a good extension. And this is his video which he sent. You can see an excellent extension and flexion at the DIP joint. It doesn't have any deficit. So whenever you get a surgical failure, again, if you religiously give a splint and follow and give a good supervised hand therapy, then patients can get an excellent result. So again, zone 2 injuries, we need to use a boxing, the basket weave technique. This was a patient with fracture middle phalanx with extensor tendon injury. And whenever there is associated phalangeal fracture, or even in patients with finger amputations when we replant, we need to do an excellent skeletal fixation with good alignment of the fracture without crossing the joint, so that you can mobilize them little earlier. But then you need to have a meticulous tendon repair technique also, and you need to mobilize them early. So you can see this fixation across K wire without crossing any joint. Plus, I immobilize the DIP joint so that at least PIP I can mobilize fast. Because I believe if you immobilize the DIP, then the extensor tendon excursion and the load on the extensor tendon over the middle phalanx reduces in zone 2, and you can mobilize them early and get a good result. So you can see this is the patient after 1 month flexion and extension, and today he sent me a video. This is 4 years post-op video, and you can see an excellent flexion and extension. Absolutely no loss of flexion and no extension lag. When it comes to zone 3 injuries, many times we get a complicated patients like this. This was a subtotal amputation at the DIP joint level, but the injury was at the zone 3. The tendon was avulsed at zone 3. So this was replanted, and this was an early photograph. But in this area, especially whenever they are associated with fractures, there are chances of adhesion. And then there are some skin deficits. So this patient led to a skin contracture. This was 3 years post-op. And when he came, but I could see that the joint was still mobile. So I could release the contracture and do a tenolysis with release by jetplastis. And this patient really did well. You can see an extension, a minor extension lag, but he has got a good flexion at the DIP joint. So no functional deficit, and this is his post-op video. You can see an excellent flexion. So whenever there is secondary surgery required, you should do it very meticulously for the better result. You should learn to evaluate the patient, what are the problems, and solve that problem properly. Many times zone 3 patients are conserved, especially the close injury, and these are splinted, and this patient presented almost 4 months after the trauma, treated somewhere else, and he had established botonier deformity with stiff PIP joint. It could not be extended passively. You can see the passive extension also not possible. So we decided to do PIP joint release and do a tenolysis and repair the extensor tendon. So it was done through a mid-lateral incision. You can see a flexor tenolysis also done. And in the post-op, you can see a minor boutonniere deformity, but then he's got no functional deficit. He has an excellent flexion. And this is his video. So complete flexion and complete extension except minor boutonniere deformity. But then this can still be corrected with the extension splint, dynamic extension splint, to be worn for a long time. Many times I advise these patients to use this splint for more than 6 months. I have yet to receive his post-operative video after this splintage. When it comes to zone 4 injuries, again there are flat tendons over here, and you have to do you can get some central tendon if it is a clean-cut injury. But many of these patients, as I said, they present late, and then it is not possible. So, but you can see a good sleep on exploration. And if I give a traction on the distal segment, then you can see a good extension of the DIP. So the joints were really mobile in this particular patient. And you can see the lower right one is the post-operative photograph on table in drop, and you can see a cascade getting maintained. So this was an extension, but then he still had some flexion lag. As I said, I always give them dynamic extension splint after 4 to 6 weeks, and they do really well after that. And this was 4-month post-op photograph. You can see no flexion deficit and excellent extension of the patient, of the finger. Then zone 5 injuries, you can obviously take a core suture. So these are a little better level to treat because the central tendon is good and you can really take a good core suture. So I prefer to take 4 strength suture now with 4-ethylon. In all these tendon injuries, my preferred material is ethylon because I believe that the knots required are only 3 and it adds less bulk to the tendon as well as in the subcutaneous tissue. So in up to zone 3, I use 5-ethylon, and from zone 3 to onward, I use a 4-ethylon. And in zone 5 injuries, you need to repair a sagittal band also. You see again a neglected wound over the metacarpophalangeal joint in zone 5. So you extend the incision and explore it. You can see the central tendon lying apart. So you repair it as well. You repair the sagittal band so that patient doesn't have a deficit in the flexion. And this is 4 years post-op video with excellent extension of the finger and excellent flexion. So he doesn't have any deficit. So to conclude, though difficult, the extensor tendon injuries can give excellent results if the appropriate technique is chosen for that patients. They need a prolonged hand therapy and that to supervise, and the cooperation of the patient for the supervised hand therapy is very essential. Without that, I find that it's very difficult to give results in extensor tendon repairs. Thank you very much.
Rajendra, thank you very much. Stay online so that we could have some questions at the end. May I now invite Dr. G. Balakrishnan to take his talk on acute flexor tendon injury.
Hello? I can't hear you.
Can you hear me now?
Yeah.
Yeah.
Pankaj, I could hear you.
Yes, sir. Dr. G. Balakrishnan.
Yeah.
Sir, for
Good
the benefit
evening.
of our for the benefit of our orthopedic colleagues, Dr. G. Balakrishnan is like the Bhishma Pitama of hand surgery in this country, and we all look up to him. I mean, he's a university by himself, and it's really a pleasure and honor to be able to hear him speak on acute flexor tendon injury. Pranam, sir. Over to you.
Pranam to you. Thanks. Good evening to all my friends there. And now I have been asked to talk about acute flexor tendon injuries. Nilesh has talked about anatomy and the healing now. Yeah.
Sir, please share your screen.
Yeah, I'm sharing my screen.
Yeah. Okay, sir.
I'm not able to join your meeting. Just a minute, I'll get it.
So you don't have to just press escape couple of times, then you will go out of full screen.
1 minute. Yeah.
Yes, now we can see, sir.
You see?
Now we can see your screen, sir.
Yeah.
Just start your presentation.
Right.
Perfect, sir.
Now, are you able to see my slide now?
Yes, sir. Yes, sir. Just start the slideshow now. So don't press on Zoom, sir. Just start. Yeah.
Yeah, right.
Yeah. Yes, sir. Perfect, sir.
Yeah, perfect now. Right. See, I just want to tell about the flexor tendon healing. It is both by extrinsic and intrinsic. The extrinsic healing produces more adhesions. Intrinsic healing, less adhesion, but always have a fear of rupture. So the duel between adhesion and rupture and the variations are legion. Coming to how this injury happens, usually by sharp cut, by blades, knives, or glass at home or in the industries. And the crush injuries happen because of the injuries at because of the industrial accidents and road traffic accidents.
We can hear you well, sir. We can hear you well.
Now, are you able to hear me talk?
Yes, sir. We are able to hear it clearly, sir. No worries.
Now, are you able to hear me?
Yes, sir. We are able to hear you, sir.
No, my talk.
Yes, we can hear your talk, sir. No problem.
Right. The contraindications for repair are the infected wound, skin loss, and vascular compromise and associated injuries. Coming to the exposure, there are two incisions described. One is midaxial, other is Brenna. The midaxial described by Littler. This is by the incisions on the ulnar side for the index, middle, and ring, and on the radial side to the little finger, just to avoid the contact surface. The Brenner is the Z incision on the volar aspect of the finger. Why this incision? All these incisions are given to prevent any scar contracture at the end of the surgery. Coming to the repair may be primary, which is done within 24 hours. It can be delayed as a delayed primary up to 1 week. The secondary after 3 weeks. A lot of suture technique he has described, but the best what we use now is the grasping modified Kessler's Mason suture, where we use 30 or 40 monofilament nylon, 40 for children. And then we add the quiet stitch, which is a 60 nylon. The recent recommendations, as all of you know, the multi-strand suture using braided polyester and suprabit, both I have never seen or never used. I'm very happy with the modified Kessler Mason sutures. Coming to where to place the suture, all of you know the blood supply is longitudinal. It is placed on the dorsal and central part of the tendon. So the suture to be placed on the avascular volar half. Coming to the repair, the tendon cap is more than 3 meters. Already Nilesh has described, is more than 3 millimeters, so gives a poor result. That's why we advocate a grasping suture like the modified Kessler machine than banal. Multi-strand technique, they say it's good, but I have no experience. I'm a strong advocate of flexor sheath repair because it maintains synovial nutrition, increases intrinsic healing, decreases adhesions, allows free movement of the tendon. How to do this? The technique of sheath repair falls on this. When you elevate or expose the flexor tendon, raise the flexor sheath as a flap, and then you can always get it back and then suture. Now, coming to the different zones, in zone 1, it's only the FDP, laceration or avulsion can happen. Proximal end lies just proximal to the FAP joint held by vincula. Sometimes even we see when it gets avulsed because of the increased force, these tendon end, proximal end may lie in the palm. Still you can get it to the zone 1 and always do a primary repair. While doing the repair, preserve the volar plate and AFO pulley. When the distal end is less than a centimeter, you advancement of the flexor tendon in suture. And this is, you see one innocuous injury on an index finger. On exploration, you could make out a flexor tendon injury. It's repaired, and what is the good result, what you see here. Coming to zone 2, Bernal said it's a no man's land because both two tendons, both FDP and FDS, are like the fibrous osseous tunnel, and they are very prone for adhesions and those days rupture also. Verdon and Kleinet was the one primarily repaired both the tendons and shown a seed for the current concept. Now, coming to the zone 2, the position of the, take the history from the patient, how was the hand or finger was. If the finger is straight, the wound, the tendons would have got retracted proximally, but the distal end will lie in the zone of injury. Whereas in an action, both ends get retracted. These are very important for you to get back and repair. Zone 2, primary repair gives best results. Well experienced, do both the tendons. Less experienced, do FDP alone. No experience, not to repair. In zone 2, you should ask, why should we repair both the tendons? It preserves blood supply to the flexor tendon profundus, provide independent motion, provide stronger flexion, retain smooth bed for flexor profundus, avoids PIP recurvative deformity. Then I was just mentioning about retrieval of the tendons. If the distal cut end has gone inside or gone into the proximally into the distally into the wound, by just flexing the finger, to get the distal end for a primary repair. Coming to the proximal end, when it gets retrieved into the palm, there are a lot of techniques, but what we feel best is the catheter method. Introduce a catheter into the fibrous osseous tunnel and then get them into the proximal palm, suture the catheter to the tendon and get them to the zone of injury. Nowadays, we even use the Venflon to pass proximally and then get the tendon. This is a case of zone 2 injury, right little, out of cascade of little finger. There's a good result on the end of 6 weeks. Coming to the flexor tendon zone 2, this is a skin flap has been avulsed. They are precarious, just viable, and we want to preserve the viability. So it didn't make any extra incision, and then we repaired both the tendons. At the end of 1 year, it's all healed well, but with some scarring. But you got a good result with this repair. Coming to the zone 3, along with the tendons, you got a lumbrical muscle. This muscle can be repaired or excised according to the nature of the injury. This is one such case where if the lumbrical muscle was just left alone and repaired and got a good result. Zone 4 is a difficult area because this comes under flexor retinaculum, under which you got all the tendons crowded and the median nerve also there. You must repair all the tendons and the nerve must be repaired, but don't reconstruct the flexor retinaculum. Keep the wrist in flexion post-operatively also on the rehabilitation time. In zone 5, it's very important to identify all the structures. Many times we have seen people have sutured the tendon to the nerve. If there is a vascular compromise, do the vascular repair first. If not, do the tendon first, nerve next, and finally vascular repair. And always the wrist should be kept in flexion post-operatively also for rehabilitation. This is injury reached us within 24 hours. Wound looks not very bad, and we could see the claw, and there was no ulnar pulsation also was not seen distal to the wound. So we opened and we repaired all the flexor tendons and then repaired both ulnar artery and the nerve, as you see here. And this is after 5 weeks. And you could see here he has got a good flexion. The tenoid sign has moved to the middle of the palm. We have to wait for a few more months whether the claw gets corrected or you do a further surgery. So coming to the rehabilitation, if you have a patient who is not motivated, do a good plastering and leave him for 3 weeks, then take it out and start the mobilization. In the motivated patient only, we follow the active movement by Duran-Hauser's method, where we give a good protection with the POP and a physiotherapist will supervise and we will give a protective passive mobilization. The complications are sepsis and wound adhesions. This can be easily avoided by a good cleaning of the wound, good debridement, and washing the wound. Rupture and adhesions are gone with the flexor tendons. You should avoid them by a meticulous repair. Joint contractions by 40, positioning of the fingers in the POP. Quadriplegia effect is because of the tight suturing of the FDP tendon. Assessment, there are many methods described, but to us, TAM system, that is total angular measurement system, is the best method, where you measure the angles of MCP, PIP, and BIP joints minus extensor deficit. You calculate this over a period of time, and you will see whether you improve or not improving. Coming, lastly, a word about policies longus. The single tendon, primary repair is the rule of the game. Secondary reconstruction, if you want to do any case, do always a tendon transfer using FDS or the ring finger. No tendon, no grafting. Optimal result can be got by the meticulous technique, choice of suture material, type of tendon repair, and rehabilitation. Thank you very much, my dear friends.
Sir, thank you very much. And we apologize for the technical glitch, sir.
Oh, don't worry. This was between me and Lord.
Yeah, extremely sorry.
About.
Yeah, extremely sorry.
It's okay.
Thank you very much, sir. Sir, be with us you just in case there are any
sure.
questions. Now I invite Dr. Ravi Mahajan, who is the president of Indian Society for Surgery of the Hand. He is going to talk to us about flexor tendon reconstruction in later presentation. Dr. Ravi Mahajan practices in Amritsar, holy city of Amritsar, and he is one of the busiest plastic and microsurgeons in North India, works in a very busy Amandeep hospital. And those who have enjoyed his hospitality will know he's a very generous host. Welcome, Dr. Ravi Mahajan.
Thank you, Pankaj. Thank you so much. So good evening, everyone. First of all, I must again welcome all the surgeons who are attending this CME.
About 3,500 are attending at the moment.
Oh, great. So I must again invite all of them who are interested in hand surgery to become members of the ISSH and enjoy all the benefits, which Pankaj has accrued for all the members with his lot of hard work. So coming to my topic, I'll be talking about the flexor tendon reconstruction in late presentations. So you have already heard legendary Dr. Balakrishnan talking about the early repair. So, but many times patients may come late to you. And if the delay is more than 3 to 4 weeks, then the direct repair may not be possible. And then the options which you have are either go for primary tendon grafting or you go for stage tendon grafting. So as far as the results are concerned, there are a lot of variables. And if the patient is of an elderly age, then the results may not be as good as you will have it in a younger patient. But if it is a very young patient, a child, then you may have a problem with the compliance. So many times you may have to wait when the child is a little older. And mechanism and extent of trauma is another thing which is very important, because if you have a clean cut injury, then the chances of you are having a good result as well as doing it a single stage repair will be much higher. But if it is a crush kind of an injury, then you may have to do a 2-stage repair and the results may also get compromised. The level of tendon laceration, what is the zone where it is injured, so that will also affect your results, and the healing response of every individual is different, so that can also make a difference. Now, if in zone 2, you have FDP as well as the FTS tendons disrupted, so what we are following is palm to fingertip tendon graft, and one graft in each finger is to be used. But if FDS is present, then you should not sacrifice it. And usually we use a small caliber graft, which is palmaris longus or plantaris. And the junction of your tendon graft has to be outside the tendon sheath. So that is the whole idea of doing the flexor tendon grafting, particularly in zone 2. And there has to be an adequate graft tension, as we will be seeing. So before you do a tendon grafting, there are certain prerequisites. One is that you should have a well-healed wound. The joints should be totally free of contracture. And something which is very important is that you should have a full range of passive motion. So many times you may have to put the patient to physiotherapy to have a full range of passive motion before you take up this patient for tendon grafting. Circulation has to be satisfactory, and at least one digital nerve should be intact. So the surgical steps. So the most important thing is to have a good surgical exposure, and for that you can use either a Brunner's incision, which is my preference, or you can go for a bilateral incision also to have a good exposure of the flexor tendon sheath. And one of the very important and steps, and which has to be done very patiently, is that you should remove the tendon from the flexor tendon sheath. And while you are doing that, you should try to preserve most of the pulley and the flexor tendon sheath. So this step actually really needs a lot of patience, so that you don't do any further damage to the flexor tendon sheath, and you are able to preserve most of the pulleys. Then you harvest your graft, and these are the various options which we have, but most of the time we are using either palmaris longus or plantaris. And then the placement of the graft is usually done with radial rodding technique, using an infant feeding tube. As you can see here, that infant feeding tube that is being used to railroad the tendon graft, and here the tendon graft has already been put. And then you have to join this graft distally, that is the distal juncture. And there are various methods of doing it. You can use an anchor, or you can fix it into the bone with the help of sutures, or you can go around the bone, or you can even suture it with the remnant of the tendon here. And as far as the proximal juncture is concerned, that is usually done with the pulver Taft technique, because there is a lot of discrepancy between the graft and the proximal end. when you're adjusting the tendon, you have to make it sure that you have a complete flexor cascade. So it should be according to that. And then in the post-operative period, you have to give the splintage in the same way which you do it after the acute flexor tendon repair. And the regime which we usually follow is again, the passive flexion and active extension, that is Durance regime. And this is an example of single stage tendon grafting where the patient came after a few months. And you can see here that the middle tendon is totally straight and both the flexor tendons are cut. And here through the Brunner excision, the whole of the tendon sheath that has been exposed. And you can see here the infant feeding tube which has been put and which was used for railroading the tendon graft. And here the tendon graft has been put and the suturing completed. And you can see it is in a proper cascade here now. And this is the final result which we were able to have with the single stage tendon grafting. Now, this is another patient where the little finger is involved. Again, late presentation and the finger is straight. And this is the flexor tendon graft which has been used here. Again, distal juncture, proximal juncture, here, proximal juncture, which is in the zone 3 with the Pulver-Taft technique. And this is the kind of a result we were able to have. And thus, there is a small lack of the flexion. Otherwise, he's having a good flexion. But if in zone 2, the FDS is intact, then you see most of your flexion arc that is maintained. As you can see here, only this much is the one which is affected by the DIP. So it should be done only in selected cases. You should talk to the patient, and then if they are really concerned about it, only then we should go with it. And it will be more important in ring and little fingers in order to restore the power grip. And similarly, if there is in zone 1, then also you can do it in the same way, but you should use a thinner graft because you have to pass through the FDS chiasma. Then coming to the 2-stage flexor tendon reconstruction, in what cases you will go for the 2-stage flexor tendon reconstruction, where there is a severe trauma and there are crush injuries associated with the underlying fracture or the skin damage, there is a prior surgical failure, or there is a damage to the retinicular police system at the time of injury or because of the prior injury. So exposure is done in the same way, you do use the Brunner's incision, and then at that time, again, here it is very important that you should try to preserve as much of the pulley system as much you can. And then you have to excise the tendon in the same way which we do it in single stage, and leaving behind just 1 centimeter of the length. And a curvilinear incision is given in the wrist crease. Then you introduce a 4 millimeter thick silicone tendon implant through the pulleys into the flexor tendon sheath. And you should have minimum of A2 and A4 pulley. If you don't have it, you will have to reconstruct it. And then you fix the distal end of the silicone rod to the remnant of the FTP tendon using a 3-0 nylon. So as I said, if you don't have A2, A4 pulleys, you are not able to preserve those, then you must reconstruct it. So I would like to stress this point here, because don't think that since you are putting a silicone rod, so the whole of the flexor sheath will be so good that it will take care of the pulleys also. You have to reconstruct the pulleys if the pulleys are absent. The silicone rod is only going to provide you a very flimsy sort of flexor tendon sheath, but the pulleys are definitely required. So proximal end of the tendon should lie freely in the distal forearm and should not buckle with the passive finger flexion. And you can see here that there is a silicone rod here which has been put, and a pulley has been reconstructed in this case in order to avoid any kind of a bowstringing. So once you do that, so you have to check by pulling it that there is no bowstringing, as you can see here, and only then you will close it, or otherwise you may have to reconstruct some of the pulleys, which we'll see how we do it. You have to put a splint in flexion, but you can start doing the passive movements as early as 2 to 3 days. So now for the second stage, you come back after about 3 to 6 months, and you just have to open it, the distal portion and the proximal portion, and then you have to expose the implant in the distal part and the proximal part, and then you do the tendon harvest grafting, and then graft, you will suture suture to the proximal end of the implant and pull it through the sheath. So distal juncture, proximal juncture, and the appropriate tension. So you can see here, this is the proximal end of the silicone implant, which is exposed through this limited incision, and this is the graft. So you are going to railroad this implant. So here we have pulled out the silicone rod, and this is the tendon which has come over here. Now the tendon is fixed distally, and here proximally, after adjustment of the tendon, the pulvotaft repair that has been done. Again, splint is done in the same way as we did in single stage. And this is just to show you an example. Here you can see the nerve was also injured, so the nerve was repaired with a nerve graft. And this is the silicone rod which is there, and we have reconstructed two pulleys also. And usually I prefer to use a tendon graft around the bone to reconstruct the pulleys. And this is the proximal part of the silicone rod, which will be kept here free. And as you can see that this is put just freely over there. That is why there is no flexion of the finger. And this is after it heals, then you come back after about 3 to 6 months, and then you put your tendon graft. And this is so you just have to open it distally and proximally. And this is after stage 2, when you have done your tendon grafting. And this is the kind of a result which we were able to have in this patient, as you can see. This is an example of thumb flexor. So whenever you have a late presentation of the FPL tendon and you are exposing it, you must make it sure that the oblique pulley which is there, that is preserved well. And this is the infant feeding tube which has been put here, and the flexor tendon, this palmaris longus graft. So that has been railroaded with the help of infant feeding tube. And this is the proximal end of the FPL. So we have done the distal juncture over here, and you can see that this is the pulvotaft repair which has been done into the proximal end of the FPL tendon. Then coming to the zone 3 and zone 5, you may have to use interposition graft or FDS transfer or end to side. And just to show you one of the examples, gunshot injury where flap were done initially, and then later we raised the flap, we did the nerve grafting, and at the same time, for you can see this was pre-op, that there is no movement of the flexor tendons of the index and and the middle finger. And now we have used interposition tendon graft also along with the nerve grafts. So 2 tendon grafts they have been used, and this is the result which we were able to have. He's having good flexion of the index as well as the middle finger. So reconstruction of the pulleys, you can do these 2 ways. The A2 and A4 pulleys, they have been reconstructed by using tendon graft. And if you have a remnant of the pulleys left, then you can do it in this manner also. And sometimes part of the FTS can also be used for reconstruction of the pulley. So these are the various complications which you can have. And then at the end, I would like to summarize that late presentation, that is after 3 to 4 weeks, will almost always require tendon grafting in majority of the patient, and single stage tendon reconstruction can be done if pulley system is not badly scarred. But if there is an extensive scarring, then you will have to go for 2-stage tendon reconstruction. With proper atraumatic technique and post-operative physiotherapy, you can get good results. Thank you. Thank you so much.
Thank you very much, sir. Please stay with us for if there are any questions. Now I invite Dr. Samrat Tauri to talk to us about what all things in hand and wrist surgery that can be treated by splinting. We've been hearing surgery whole evening. And while Samrat loads his talk, there is a question for Dr. Balakrishnan. Sir, can you hear me? So, the question was if there was a flap to be done on exposed bone, a composite loss, would you do the tendon reconstruction at the same time if you had to graft the tendons? And if you do, wouldn't that make rehabilitation more difficult?
Yeah, you yourself has given the answer. When you do a flap, you are not supposed to do any grafting. You just do the flap and subsequently go in for your tendon grafting technique. Because when you are doing a flap, you may do a cross finger or any finger you do, one side is open. So there is a lot of chances for if you put a graft or even a elastic rod, chance of infection are more. Is that
Okay, sir. Thank you, sir.
anything else?
No, sir. So far, there was this question. Samrat, can you share your screen first, please?
Sir, am I audible? Am I audible?
You're audible. You need to speak closer to the mic. Okay. But please start sharing your screen.
So can the screen be seen, sir?
Yes, please speak closer to the mic. GB sir.
Yeah.
I will mute your mic now.
Oh yeah.
Yeah. Thank you, sir. Thank you for staying with us for so long. Samrat, over to you. Samrat is a practicing hand surgeon in Nagpur.
Thank you, sir.
He's extensively traveled and he's going to share his experience about splints and in hand and wrist.
I thank the organizers and Dr. Lard, and this is we'll talk about splint for hands and wrist disorders, whatever time we have. And the pertinent question to answer is, does the patient require splint? If he requires, then we have to prescribe that, because if the limb does not require rest, it requires mobilization protocol as well. I'll run through a few of the first slides. Is limb elevation. I want to stress here is because all these patients who are waiting for surgery, who are waiting for evaluation, or probably just have got blunt trauma and require some immobilization and limb elevation. The thing is that the injured part should be splinted well, maybe in a position of rest, or as the injury has bears upon that. But at the same time, there should not be any constriction. There should be a pillow cover sling, which we prefer, and the elbow should be very well supported. So in anatomic consideration, we know that this is the line where we actually get the metacarpophalangeal joint. And so for the volar slabs or the volar splints, it should not be beyond this brown line for the MCP joint to be completely free. At the same time, it should be ulnar to this particular line so that the thumb can be very well used. Jib James position, metacarpophalangeal joint in 90-degree position, and the IP joint in complete extension. This is used in most of the surgeries, post-op surgery, post-op cases, and most of the acute injuries. And one is a moldable splint. It should always be there. And we have also used POP and a Kramer wire for the same. So in most of the injuries where the patient is still waiting for the evaluation and investigation, we can immobilize in this position. In cases where we have flexor tendon injuries, as we have just seen, and cases where we don't want the extension of the finger in any way, we can use this particular way. The conservative for again, like a conservative management of fracture of phalanx in a Jib James position, and then mobilize in a body strapping. Wrist splint. So in cases where we have a blunt trauma, we have got synovitis at the wrist. In cases of a carpal tunnel syndrome, where we want the position of the wrist to be in 20 degree of extension, this wrist splint is handy. And we don't endorse any particular brand, but it has to be just proximal to the metacarpophalangeal joint to give the best results. It is also used for the post-operative therapies. So I at times use the same cast, cut it, and use it for the rest. This patient was having synovitis, and he was waiting for the synovial biopsy here. And in the ward, we had used this to give rest. The idea is that the pain should be patient should be relieved of the pain, because if that's the thing, then the other fingers he will be moving well, and he can also use the hand. Finger injury, cord splint is good because it can be used when we want to save the fingertip from getting injured again. So if we have an injured fingertip and we don't want it to be to touch here and there, we can use a cord splint like a helmet. And it's also useful when there's a blunt trauma and we just want to give rest to the DIP and the PIP joint for some time and then mobilize them. Alufoam splint, I would say, as a workhorse for all the hand injury, for finger injuries, and can be used when there are phalanx fractures or the nail bed repair as a fingertip injury. And many situations can be managed by a gutter splint. Here, It's like a PIP and a DIP are kept in complete extension, and it's just to give rest to that part. Maybe when there is a volar plate injury, or when there is only a blunt trauma or a very undisplaced fracture, it can be used. It can also be used when we want to prevent the PIP joint flexion contracture. It can be used, and for the same. I've put this example because just to stress that if we have got a fracture, we have reduced it, and we don't have a splint, we have to make a point that we do something like we have used a syringe here to give a splint. So the idea is that to splint what requires rest and mobilize what is healthy. So again, a dorsal blocking splint. So this splint can be used very well where we want to, so this proximal phalanx, there's a PIP joint fracture dislocation. It has been reduced. And now we want to mobilize at the same time, give an extension block here. So this splint is in a slight flexion here. So the finger is kept in flexion. At the same time, the distal part is in Velcro. So it will be removed. The finger will be, the patient will exercise at the PIP and the DIP joint and again use it. And the angulation here will be gradually decreased so that at the end of the 4 weeks, the finger will be completely straight, and this will be enough. This works very well for the conservative management of the fracture dislocation of the PIP where it has been reduced, and now we would just want stability at the same time, start mobilizing at the PIP and the DIP. Captain's splint is favorite of hand surgeon. We have discussed it throughout the day. Morning to be I'm sorry, in the earlier sessions we have discussed it. So it's for the conservative management of the central slip injury, the zone 3 of the extensors. The idea is that the PIP joint is kept in complete extension, and the DIP joint is completely free. And the patient, for the central slip injury, he wears this splint and he does a PIP joint movement, does not do a PIP joint movement, but does the DIP joint movement continuously so that the volar subluxation of the tendons, lateral bands don't happen. And it's quite reliable, but it has to be worn for a long time. It's also very much useful for flexion contracture, maybe because of a post-operative case or a volar plate injury, and then leads to a flexion contracture at the PIP. It's useful. Mallet finger, very well discussed by Nete sir already, but I generally manage them with this particular type of splint. So for a soft tissue mallet, the splint is in 15 to 20 degree of extension, and we keep the splint for 6 weeks, 4 to 6 weeks, 24 hours, another 4 weeks for at night time. For bony mallet like this, we take a lateral X-ray, we see this, we put a splint, and then we take an X-ray with the splint on. If the bony fragments come together or they are just nearer to each other, that means it's going to work, and the protocol is the same. Some people prefer to put it on the dorsal aspect, and this is a 3D designed splint from KMC Manipal that can be also used. Trigger finger, interestingly, in the earlier stages when there is inflammation, when there's just pain, or in the situation where there's occasional triggering, we can use the splint. It just blocks the MCP joint flexion, and definitely it eases out the FDS. It relaxes the FDS for some time. FDS and the FPL for some time. And again, for giving rest to the FPL, we can use this simple aliform splint. I prescribe this for 3 to 4 hours in a day for about 14 to 21 days. There are papers which describe it as a night splinting for the same time. Thumb splint, decurvent tenosynovitis can at times be managed very well by just rest to this part. So thumb spica splint, where we give rest, we can give rest to metacarpal phalangeal joint, carpal metacarpal joint, and also the wrist area where we want to give rest in the decurvent tenosynovitis problems can be very well used. In situations where we just want to manage conservatively fracture in the phalanx region or in the metacarpal region of the thumb, at the same time keep the wrist completely mobile, we can use a customized type of splint here. Carpal tunnel, as I've said, in early stages, in the cases where the patient has got the sensory symptoms only at when there is a volar flexion of the wrist, it can be used for night splinting. At times, it can be used 24 hours. The patient, if the patient gets relieved of the symptoms by this, it's very good. Nothing has to be done later. So nerve injuries, we have splints, and basically we have to consider three things in nerve injuries mainly. One is that the paralyzed muscles have to be kept in a position of relaxation. They should not be overstretched, and till the time that either they recover or we do a tendon transfer. Second is that we want to prevent any undue contractures because of the motor loss of one group of muscles. And third is that there will be some altered sensation in particular area, and that has to be taken care of while we design these splints. So this is a palmar abduction splint of the median nerve, and this is a palmar bar. So this can be without a bar or we can be with a bar there. Radial nerve palsy, I prefer to use only a splint which has got a dorsiflexion of over 20 degree at the wrist, and the fingers are kept free, the MCP joints are kept free. The idea is that the intrinsics will be taking care of the finger of the extension of the IP joint, and there will be some patient will keep on working, will move his hand and fingers, and we wait till the radial nerve recovers or we plan for a tendon transfer. We have to be very cautious if we are using this particular type of splint where we have a passive extension and the patient is supposed to do dynamic, patient is supposed to do active flexion. Sir, 2-3 minutes, I'll take more. Pankaj, sir.
Yeah, sure, go ahead.
Yeah. So if the patient is not going to come to us every day, and if we are not sure that this is going to work, it's not a good thing to manage patient with this passive extension and active flexion, because they may develop contracture at the MCP joint here. The concept for the knuckle bender splint is to correct the clawing in the ulnar nerve palsy, also to prevent the clawing in the ulnar palsy. At the same time, the patient can strengthen his flexors here because they are free. Dupuytren contracture, we use a pan splint which has got which keeps the MCP joint in complete extension, the PIP and the DIP joint in complete extension. This is a post-operative splint, and once we release it, we have to put the patient on this, and the patient removes it and does his exercises again and again puts it on. I have used another way of making the same thing, but this is commercially available. Body strapping is of great help for the conservative management and also for the rehab in cases of fractures, injuries of the metacarpal and the phalanx as well. In cases of blunt trauma as well. The idea is also it is useful when we have done a tendon injury, tendon repair, and then this can be body strapped to an adjacent normal finger, and it helps in the excursion of the tendon when the patient is mobilizing. So the point here is that there has to be a gauze piece between the two fingers so that there is no maceration, and at the same time we have to keep the joints free. If the patient is doing this strapping himself at the home, then preferably he should do it in with a paper sticking so that it's not tight, too much tight. Last few slides. So metacarpal phalangeal joint stiffness, we can use a digital loop, finger loop thing here with a rubber band and a safety pin on the side, so it causes continuous traction at the MCP joint. At the same time, patient can do a active extension as well. And the point is that all the fingers uh, uh, they point towards the scaphoid. So all these rubber bands will go towards this side. So this is an OPD thing which can be done, and it's always handy to have rubber bands and safety pin and Velcro with us in a pocket. This is another way of doing this, but then this strap, we have to understand that it has to be very narrow so that the metacarpal phalangeal joints are free. This is for an individual finger. It has been done. For stiffness of the IP joints, we can use a glove thing, which is the part of the fingertip here is cut, and then we force the IP joints into flexion, and then we can use it. Similarly, this can be done in this way. Yeah, I thank you. Thank you. This is the end of it. I hope
Thank you, Samrat, and sorry to keep you waiting late, but I would still want to take a couple of questions. Dr. Balakrishnan, there are a couple of questions for you. Are you around, sir? Sir, can you hear me? Dr. Balakrishnan, can you hear me? Yeah. I think he is away. So I will put that question to Dr. Ravi Mahajan. Would you ever consider a flexor tendon repair without a core suture?
Without a core suture, no,
Yes.
I don't think because the core suture is very, very important to provide strength. And as we all know, that the strength of the flexor tendon repair is very important. So I don't think I'll do that.
And another question to you, sir, is when you are doing a late reconstruction, how do you know that the muscle that you are attaching distally again is contractile enough? What if it has lost its contractility? How do you choose? What is there a time frame? Is there a clinical examination? Is there a laboratory test?
Well, I don't think there is any objective test to do that. But if a long time has elapsed, then definitely there are chances that that muscle may not be strong enough. So in that case, probably if say more than a year or something has elapsed, then what probably you can do it, you can attach it to the adjacent tendon. You can do the tend to side. You know, that that is what we can do instead of attaching it to the same muscle. Then you can do it to the one which is already working and do it end to side with that.
Yeah, if I have to draw analogy from shoulder surgery, where before they undertake any rotator cuff repair, they do MRI to check the fatty infiltration in the muscle. Perhaps that can be one of the answers. I'm not sure whether it is, but perhaps it can be. There is another question, Dr. Rajendra Nehete.
Yes.
Would you ever consider a primary repair of a tendon in human bite? I'm putting this question to you because human bites will usually tend to have extensor tendon ruptures.
Yeah, especially in zone 5 on the knuckles. During the fight, they get the human bite on the extensor tendon rupture. I have seen two patients. One patient who primarily presented to me, but I always prefer to wash them, debride them properly, and repair them primarily. I have no problem. But I had one patient who came secondarily to me after getting infected to the extent that I had to excise his MP joint. So if the debridement and lavage is not adequate, you may face a problem. Plus, you have to start the antibiotics, and you need to know the organisms in the oral cavity. So you need to give something for the anaerobic organisms. It is the anaerobic infections which are very common after the human bite. And you need to give metrogel, for example, with higher cephalosporin. So that's take care. So I would not, just because there are chances of infection, I would not postpone the surgery. I would do it primarily.
Yeah, thanks, Ajay. Dr. Mahajan, another question for you. Do you think the size of the tendon matters when you use it for grafting? For example, is a palmaris longus a good substitute for FDP, where there is clearly is going to be a side mismatch? Does the strength matter?
See, the more than strength, I will say what is important is that it should not get entrapped in the pulley system. So that is why, you know, it has to be of it has to be a little thinner. You know, if it is bulky, then there are chances that it will not glide very well in the flexor tendon sheath. So gliding is very important. And if you have done your repairs on both the sides very well, so ultimately, it is that muscle which is going to do the work. So if your both tendon ends, graft ends, they are going, they will heal well. So then I don't think there will be any problem. But if the size is bigger and it doesn't glide well, then it is going to be a problem.
Perfect, perfect. Okay, Samrat, there is a googly question for you. What splint would you recommend for a tourniquet palsy? Tourniquet palsy patient whom you are waiting till he recovers, what splint would you recommend?
Wrist.
Samrat, are you able to hear me?
No. He has done it now. Yes.
Yeah.
So we are talking about a triple nerve. All the
Triple nerve tourniquet palsy.
median, ulnar nerve.
Yes.
Sir, I'll be making a POP slab and customize. And what I want is a dossier. We'll keep the wrist in neutral, the MCP joint in in 90 degrees of the flexion
What?
and
Yes, yes.
the thumb in abduction.
And the support
That
to
would be
the.
my thinking, because I want, well, the seniors can
Yeah,
talk about this.
Anil, do you want to add anything to it?
I mean, like yesterday's SRS told about, in terms of obviously no recovery and there's no options because of the triple now palsy. At the end of the day, if at all it becomes stiff, I think it should become stiff in a functional position or a, more useful position. As Samrat said, it's right that you have to keep the wrist in neutral and then get the thumb out, and whatever reconstructive procedures or any kind of thing which at all happens later, we need to maintain this till we go to that particular stage. That's right what Samrat has said. Yeah.
Sir, I want to add one thing, which is, I think, more important is like remove the splint and keep all the joints supple. That is probably
Okay,
very,
so
very much
split.
important. Yeah.
So you have to balance between immobilization and mobilization. Yeah, thank you, gentlemen, all of you. It's been a long evening, but I would still want to summarize the session.
Pankaj,
So, yes, sir.
can I
Yes,
give
sir.
something?
Yes, sir.
For
Tell
the
me, sir.
question what you have asked about the tunica palsy,
Yes, sir.
yes, we give a splint only at night.
Okay.
Daytime, you should make the fellow to move his finger actively, and actually he may not do passively, he must do himself.
Yes.
And massage of the area where there has been tunica was there. We have to assess by, as Sababhi also told, by frequent neurogenic studies to find out how much it improves. Renal sign is one of the important things to see in those things.
Yes.
And then because this is not like the VIC, where you have a palsy, muscle necrosis or anything, going to be maximum nerve palsy. Thank you.
This is a classic case of difference between knowledge and wisdom.
Hey, come on.
Thank you. Thank you very much, sir. I would just briefly summarize the session, because I think the first session went about 4 hours ago. So I think from Rohan's talk about radiology, the most important point I felt was a good 30-degree lateral to look at the lunate fossa. Dr. Warrior's talk, I think the incision, to make a dart in the incision to reduce the hypertrophy, I think it's wonderful. It's a problem that all of us have felt. Dr. Patankar's case waiting to be published for the intramedullary nailing, I think it's a fantastic method of from surface fixation to intramedullary fixation for the radius, just the way we have moved from for fracture ITs. From my own talk, I felt the most important thing that I wanted to share was the extensor tendon damage that the volar fixation can do. Abhijit did tell us about that the world is still divided when it comes to fixation of ulnar styloid. There is support for either ways. What matters eventually is the instability of the DRUJ, and if you can attribute the DRUJ instability to styloid, by all means, we all need to fix. Dr. Anil Bhatt spoke to us about proximal pole fracture, and I think the important take-home point is be aware of the size of the screw that you're using. You really need to use a screw head. The trailing end should be about less than 2.8 millimeters. If you are dealing with less than 5 millimeter of proximal pole fragment, otherwise you would shatter it. In terms of graft for non-union of the scaphoid, Amit spoke about vascularized bone grafts when there is no humpback deformity, and iliac crest bone graft when there is a humpback deformity. Prashant, perilunate dislocation, wonderful talk. When you, between all the ligaments that get disrupted, repair the scapholunate ligament and then wire it, whereas the lunato-tricutal ligament, you can simply wire it. It's better to put 2 wires across the lunato-tricutal ligament, 2 parallel wires. Kinbox Bipin introduced us to Leishman's newer grades, which was grade 0, where there is intermittent ischemia, and grade 3C, where there's a coronal fracture. I think the Bain's classification also talks about this coronal fracture of the Kinbox of the lunate. Thank you, Bipin, for telling us that. Nilesh spoke about hand infections. I think the most important part is not all are the same. You must know your organism so that you can treat it individually. There is no panacea here. Parag, always there is aggressive surgical management and always send the sample for gram testing, Zil-Nielsen testing, as well as histopathology, because you will be stumped by occasional tuberculosis and sarcoidosis. Then we had Nilesh speaking to us about principles of tendon repair. I think the gold standard still is a repair, no matter how much newer solutions that we are looking for, a glue, vitamin C, a good tension, good repair without bunching up the tendon is still the gold standard. Dr. Balkrishnan spoke to about acute flexor tendon injury, and one important point he made was for flexor pollicis longus, either you can do a primary repair or you should graft. Avoid doing any, either primary repair or transfer. Avoid doing any graft. Dr. Ravi Mahajan did show us a graft, but Dr. Balkrishnan was very categorical about, as far as FPL is concerned, either you transfer the FDS or do a primary repair, avoid grafting. Dr. Rajendra spoke to us among all the techniques that he told. In the beginning, he said, no matter what you do, the extensor tendons in zone 1 to 4 continue to give poor results. And I think it's been experience of most of us. Dr. Ravi Mahajan spoke about late reconstructions, and he spoke about the importance of pulley reconstruction. So it's the pulleys which are going to decide your outcome in late reconstructions of the flexor tendon. Samrat spoke to us about various splints, and one of the important splints was the Kapner splint. When he said the Kapner splint needs to be used for a long time, doesn't mean you have to use it for a long duration every day. It's just that you may have to use it for months together. But on any particular day, the Kapner splint should not be worn for more than 15 minutes at a time. And it should never be used as a night splint, or you should never go to sleep with a Kapner splint, otherwise you'll wake up with a black finger. So that more or less summarizes today's long session. And I thank all my faculty who has stayed with me throughout this evening. And if there have been any glitches, any mistakes, I offer sincere apology. Over to you, Parag.
Yeah. I thank all the viewers. Just now, I just checked 4,600 viewers till now. And I really thank all the faculty again. I again, once again, acknowledge and thank our event partner, SYS Meditech International Private Limited. Stay tuned for us and see you tomorrow at 4 o'clock in the evening. Thank you so much, everyone.